could just ask all those not speaking in a session to mute themselves. You're all muted upon entry, but if you opened yourself up for conversation, which was very welcome, please go ahead and mute yourself now, unless you are part of the presenting panel. So hello, everybody. My name is Yarada Abrahamian, and I am the chair of Guidelines International Network in North America. Welcome to the 4th EGAPPS conference, which GIN North America has the honor of co-hosting with our longtime partners, the section on evidence-based healthcare of the New York Academy of Medicine. We all just marked the 1-year anniversary of the COVID pandemic, a global catastrophe that challenged our healthcare systems, robbed millions of their lives, of their loved ones and their livelihoods, and it traumatized our colleagues on the front lines, and those of us providing support to them. But alongside the seemingly endless long days and nights, especially during the recurrent surges, this pandemic also served to showcase the camaraderie in the healthcare and scientific research world, and the selflessness of our frontline workers. And it amplified the purpose of our guideline and systematic review community, those of us gathered here today. As a guideline developer and evidence-based medicine specialist at Kaiser Permanente, Southern California, I take great pride in being able to respond to our clinician colleagues that I have the answer. I will find the answer to their question, and I will find it in peer-reviewed published literature and present it to them with a healthy dose of critical appraisal. During the pandemic, however, and working closely with our tenacious physicians being redeployed to the hospital setting, I was deprived of that luxury. The answers were not there for me to find. What was there was not peer-reviewed, and what was there was not worthy of a critical appraisal. I know you will relate to my story because it is the news story of our community. We are here to share our stories, to mark similarities, and to learn from differences, and to charter a new path of effective and efficient collaboration. This year marks the 10th anniversary of the formation of the North American Regional Community of GIN, and the significance of this virtual conference at this juncture in the course of this pandemic is noteworthy. I thank our esteemed speakers for taking time from their impacted schedules to share their insights with us today. I thank our organizing committee and the offices of GIN and NIAM, and mostly I thank you for taking a few hours to and to look ahead to the other side of this experience together. So thank you for coming. And now I'd like to ask our GIN board liaison to the North American community, Craig Robbins, for a few words of welcome. Craig?
Great, thanks so much, Yarada. It's great to see so many familiar names in the participant list here for our virtual conference today. For those of you I haven't met, my name is Craig Robbins. I'm a family physician with Kaiser Permanente in Colorado, and at the KP national level, I help to lead our national guideline program. And as Yarada mentioned, I'm also on the board of trustees for Guidelines International Network. And we're really thrilled to be a sponsor of this conference again. GIN North America was the first GIN regional community, and we really, at the overall GIN level, we're really proud of the work that GIN North America has done and continues to do in evidence-based guideline space. We're thrilled to be sponsoring this event. We'd like to thank the New York Academy of Medicine again for their partnership for this and for all the prior EGAPPS conferences. This is the 4th one, as Yarada mentioned. And as she also mentioned, it certainly has been quite a year since the pandemic started in early 2020. So I think we're all looking forward to learning from each other today and tomorrow about the challenges that COVID created, and especially in terms of monitoring evidence, guideline development, and how we can improve in the future. So without further ado, I'd like to turn it over to Dr. Peter Wire.
Good afternoon and good morning for those of you who are a little bit further west. On behalf of the New York Academy of Medicine and our section on evidence-based healthcare, I want to express our appreciation to Jen and particularly to Urato for making this fourth in the series possible. Our relationship, the relationship of our section to GIN North America could be described as a networking partnership. The name GAPPS, Evidence-Based Guidelines Affecting Policy, Practice, and Stakeholders, in many ways embodies the concept of our relationship and the concept of the conferences. The GAPPS conferences try to bring communities together that ordinarily, despite their common interest in healthcare, don't particularly frequently communicate. And that's been our mission all along. The gaps in GAPPS, therefore, it's not so much evidence gaps, but gaps in interaction between those communities. I hope that everyone attending this is able to convince themselves that they are part of the program, the networking and interaction that occurs in these conferences is really the deliverable of the GAPPS series. And we want everyone to feel as much as is possible within this somewhat strange environment and framework of a webinar to feel that they are that. Now I want to introduce our keynote speaker. Michael Dowling is the president and CEO of the largest healthcare provider in the New York region. He's been an outstanding spokesman and opinion leader in healthcare in the region for decades, going back even before that. He's been very important to the New York Academy of Medicine as a member of the Board of Trustees. And he, as a member of the governor's COVID surge planning council, he's been in the eye of the hurricane throughout the whole pandemic that swept the New York area. And I can't think of anyone more appropriate to set the tone and the perspective that we hope to achieve in this conference. Dowling.
Go ahead, Mr. Dowling.
Oh, all right. I didn't know. Okay. So first of all, thank you for the invitation. Just to say a few words at the beginning. I really, really appreciate it. And I wish everybody the best. Have a very productive conference where people can learn from each other, because there is a lot of learnings to be had as a result of what we have been through. So I'll be relatively brief because I know you need to get on with the substance of your program, but let me start by basically stating the obvious. That is that we have been through a very, very unique year. In many ways, I think that if we look at it carefully, it's been transformational. It's a year that has tested us all. And I believe, despite some problems here and there, that the healthcare industry responded quite well. We dealt with it, and we were at the epicenter here in New York, as was just mentioned at the very beginning. And just to give you just a number, we at Northwell and my health system alone, we have actually seen over 190,000 COVID patients since the beginning. At one point, a year ago, we had over 3,500 COVID patients in our hospitals on a daily basis. But because of the work of the frontline staff, and I will come back to this later, because of their compassion and their heroism, we, I believe, withstood the avalanche of COVID at the very beginning in a way that we would not have been able to do if we didn't have the type of staff we have on the front lines of healthcare. And I think I can say that about any healthcare system in the United States, where the frontline staff are absolutely unbelievable. We also, during COVID, and it's important to keep this in mind, and I believe that we demonstrated the importance of healthcare to the security of our local communities. That's not unimportant, because healthcare often gets criticized a lot. Hospitals get criticized a lot. But when you are in the midst of the COVID crisis, the trust that we built up with our local communities was pretty phenomenal. When everything else pretty well fell apart, the hospitals were there as the mainstay of a defense against this virus. Now, obviously, COVID highlighted some of our strengths, and obviously it also highlighted some of our deficiencies and our weaknesses. And as I said at the very beginning, and as was said in the introduction, there are lots of learnings here. And I believe very, very sincerely that we have all been changed as a result of the past year, because nobody else has gone through a year like this in our history, in our particular individual history. So we've been changed. We've been changed as individuals, because I think we have a different perspective today than we had before, but we've also been changed as an organization. But it's just not only healthcare. Every organization, whether you're in the aviation industry, the real estate industry, the restaurant industry, the travel industry, all have been dramatically changed. Every business now has to look at the world in a renewed way, in a different way. And I also want to point out that we are in this for many, many years. COVID is receding right now, at least in this part of the world. Today, for example, in my health system, we have about 800 COVID patients, and the numbers have been coming down. That's a big difference from where we were a year ago with 3,500 on a daily basis. But the virus, let's assume, recedes here in New York. Let's assume it recedes into the background a little bit because of the vaccination, which we are very heavily involved in, by the fall. And let's assume we get to the end of this year and COVID is not the problem from a medical point of view that we've had all this past year. That does not mean the COVID crisis is over, because the economic implications of COVID are going to last for 5 to 10 years. So we can't fall into the complacency attitude of saying, well, COVID is over, therefore everything is going back to the way it was before. I think we have a long haul here, and we should be very actively involved in how to reclaim the economy that is dramatically affected by COVID. But overall, I would say that because of the year we've been in and what we've been able to accomplish, I think, and I've said this in many, many occasions, I think that we will be better off for it, because it has given us a new perspective. I think we've looked at things differently. We now are looking at things differently. So we will be a better organization. I think as individuals, quite frankly, I think we'll be better in the future if we keep our perspective intact. And because one of the things COVID did to all of us, whether organizations or individuals, that it demonstrated our fragility. And I recall back at in New York before COVID hit, everybody was doing well. The economy was strong. The health system was pretty robust overall. Everybody felt secure. And all of a sudden, the virus hit, and it humbled us in a way that I don't think we have been humbled before. So I think we'll be better off at the end of the day because of the learnings. And so what I'd like to do is just pose 6 or 7 questions. And I know that you'll probably deal with many of these as you go through your program. But these are important questions, in my view. I will not be able to deal with them in any great detail. I'll just pose them and give 1 or 2 examples. But I think they're fundamental. And of course, I could come up with 20 questions, but I'm going to keep it to 6 or 7. And the answer to these questions, I think, are going to determine whether we have learned anything and whether or not we are capable of making the changes going forward that we need to make. So let's take the first question. And that is, how do we build and enhance our disaster preparedness infrastructure? Not just only nationally and statewide here, but organizationally, because every single organization has to address this question now. Because as COVID recedes, do not fall into the trap of believing that we won't have something like this again. And let's not fall into the trap of getting so complacent that we don't have to rethink about how we get prepared for the next one. Because I could give a long sermon about how we were ill-prepared for the one we just went through. So how do we prepare and develop and enhance a disaster preparedness infrastructure? That deals with the talent that we need to find and recruit. It has to deal with the overall infrastructure of emergency preparedness that we need to put in place. It has to deal with the surveillance systems that we need to employ, develop. That goes for every individual healthcare system and hospital. What kind of surveillance methodologies can we determine? And we've done many of these here at Northwell in our organization, so that we can anticipate what's going to happen, know what's going to happen before it happens, even in our local communities. And there's a real clinical aspect to this. So that's the first question. The second question, to me, is a very, very important one. And that is, how do we maintain a culture of creativity and innovation that was so evident during COVID? This past year, just like most crises, this is not unique. It happens when you ever have a major crisis or a disaster. Innovation blossoms, creativity blossoms. You do things very, very quickly. You change your processes quickly. You do things overnight, and we did things overnight that under normal circumstances would have taken us months and months to do. I remember one particular example when at 4 o'clock on an afternoon here, we knew, given the surge of the patients coming in, that we had to create 200 new beds overnight. Now, under normal circumstances, if somebody said that you had to do that, you would put a planning group together, you would put a business plan together, you would get all of your architects together, et cetera, et cetera. But in a crisis, and like we had with COVID, we didn't have time for any of that. We actually created 200 beds. So when we came in the morning, there was an extra 200 beds. One of the reasons we were able to do this is that government dispensed with some of the encumbrance of regulations that were in place. They allowed us to be flexible. They got rid of and dispensed with, as I said, many regulations that had been in the books for a long time. So now as we go beyond COVID, going forward, and this applies to the clinical arena as well, because I know you're going to be talking an awful lot about the clinical issues. But so much innovation and creativity can occur if you're not curtailed by unnecessary, inappropriate micro-regulation by government. And I'm not an anti-government person. I spent 12 years of my career in government, but we would not have been able to be creative during COVID if some of these things had not been changed and we were not allowed. And if we had not been allowed to be creative, we could not have done that. That's a big question as we go forward. How do we maintain that continuous culture of innovation? Because if you're going to do something different, you're going to break some rules. If you don't break rules, you're not innovating. If you're totally, completely bureaucratically compliant all the time, and you don't push the edges of the envelope, you're not being creative. A culture of regulation, excessive regulation and compliance is the antithesis of innovation. You cannot have both. So that's the second question. The third question, how do we adapt to the changing nature of work? That has to do with issues around, the percentage of our employees that will be post-COVID now working remotely. I, for example, have 10,000 employees now working remotely. If you had told me pre-COVID that I would have that many of people working remotely, I would have probably told you you were crazy. Or I would have told you that, yeah, it is possible, but it will not be productive and efficient. Yet we find that it is more productive, more efficient. Location is not as important anymore with regard to where you live vis-a-vis where you work. That is true for every industry. Many of the people who worked in Wall Street and had to travel into Wall Street every day before COVID, many of them now will be working remotely and won't have to travel into the city to go to Wall Street in the future. That applies in healthcare as well, for certain things, not for everything, of course, as you all know very, very well. Because our relationship with technology has completely changed as a result of COVID. And the question for all of us, whether we're in the clinical arena, the administrative arena, whatever, or the research arena, is that as the location of workers and the demographic of the workforce changes, how do we maintain that culture, the personality of your organizations you need to maintain if you're going to be effective long term? That is a challenge for leadership in a big, big way going forward. The next question is, how do you become customer obsessed? What I mean by that is, as probably it's very clear to you, customers, in my view, are your patients and your patients' families. And I use the word customer because they have the ability to shop around, to go different places, to look at the different outputs from the different organizations and make choices. So how do we, as we go forward in the delivery of care and in everything that we do, enhance access to our product, healthcare? And how do we enhance convenience? Because it is very obvious that when you ask the consumer about how they measure quality, they talk about service and convenience. We inside healthcare define quality differently. We define quality from the perspective of what we think, but ask the consumer how they define quality, and you do get a bit of a different answer. And therefore, that is very instructive as we look at what we do clinically going forward. So the next question, and this is a big issue, major issue, that we have always known before, but highlighted dramatically during COVID, and that is, how do we respond to healthcare inequities, especially in those communities that are ill-served by the current delivery system? What kind of strategies do we need to put in place? It is one thing to be working in these communities to do testing to identify COVID, or to vaccinate so that you can prevent the onset of COVID, hopefully. And that will take precedent now for the next couple of months. But the question is what do we do in these communities post-COVID? When all of this is over, what is the sustainable strategy that we need to have to enhance the commitment to services in those areas and reduce the inequities? This is a major, major challenge for the industry, clinically, administratively, strategically, and otherwise. And then I have two other questions. The next one pertains directly to a lot of the things that you'll be discussing over the next day and a half, and that is, how do we redesign healthcare delivery now? And that poses questions about what we mean by a hospital in the future. What is the hospital of the future? It is different today than it was 10 years ago. How do we look at the role of hospital in the continuum of care? What should be done outside the hospital that should not be done anymore inside the hospital? And many countries, many places have made that transition. Some places have not made that transition at all. I'm dealing with some countries that have not made that transition, that still think that almost everything you deal with has to be done inside the four walls of a hospital. In my view, a hospital of the future is primarily an ICU. You deliver babies and you take care of very, very sick, chronically ill patients who are mostly elderly, And the whole issue of how to be age-friendly will become unbelievably important with regard to what goes on in hospitals in the future. Another major issue that became very obvious during COVID, and this is a central point for me to mention to you, is that during COVID, we demonstrated the benefits of interdisciplinary delivery of care. Every clinical department, every discipline, all came together in almost complete unison, working together, no silos. Everybody held hands in unity. We had dermatologists helping out in the ICUs. We had orthopedic surgeons helping in the ICUs. All came together. So the traditional silos and the clinical silos that traditionally have existed kind of disappeared because we all had to pull together in the crisis of COVID to do things and to support the continuum of care in a way that we never did it before. How do we maintain that culture? How do we prevent us going back to the silos, the clinical silos that we're so famous for going forward? That requires, obviously, the whole effort around care management, coordination of care, care navigators, breaking down the departmental silos. I believe, for example, in the future, the clinical departments are anachronistic because no one clinical department can deal with the holistic aspect of a patient without dealing with others. And our medical education is built around this, except for some changes that are being made now in some places. But that's a big, very, very, very major issue. We, during COVID, put together a clinical advisory group. And every single day, that clinical advisory group, which was made up of multiple departments, continually issued multiple times a day new treatment methodologies about how to respond to COVID as it evolved. And it was multidimensional. And we have actually a book almost of the new clinical protocols that were put out by our clinical advisory team. And the question for healthcare going forward is, should not be a continuous institutional part of how we operate going forward and not go back to the old ways. And the other subset of this question would be for us to think, and I would ask you, your speakers, to think of the following two issues. What is health? How do we define it? We are, quite frankly, most of us in the medical care business, but not necessarily in the health business, if you define health more broadly. What is health? It's more than the absence of illness. It's a heck of a lot more than what we do on a day-to-day basis. And if you're dealing with the inequities of healthcare in many of the communities that have been disproportionately affected, ill health is a result of lack of employment, poor housing, inappropriate schools. All of that is related to health. Gun violence, which I strongly believe and have been very vocal about this, is a public health issue. So what is health? Ponder it as you go through your program. And the second part of that is, what is quality? We throw the word quality around all the time. We'll improve quality, we'll do this. What is it? You have to look at it from the perspective of the provider, but you also have to look at it from the perspective of the customer. Quality is a lot more than just saying, for example, that you left the hospital after surgery and you didn't return within 30 days, so therefore that's good quality. That's a little piece of it. What is it? Worth a lot of thought. Because if we don't redefine what we mean by health and what we mean by quality, I don't think we're going to make the changes we need to make as we go forward. The last question I just posed then is, how do we promote trust in and investment in science and research? Because without an enormous investment in science going forward, which has been neglected for many, many years, and I'm sure many of you would agree with me on this, and if we don't trust science, and we've had enormous evidence of the lack of trust in science in the United States over the last 4 years, I think that we will be missing the boat about what we can do to prevent and react and respond to the next pandemic that we are definitely going to have in the future. So these are some of my questions. These are all leadership questions, but they're the questions I think that we need to be thinking about now. And leadership, in my view, and I'll end with this, leadership is required now in healthcare more than ever before. Leadership does make sure that we don't go back to the old ways and that we don't believe in the concept of nostalgia. You know, it was wonderful before COVID, so let's go back, because, you know, as you all know very, very well, nostalgia is not a practice, it's not a strategy. But leadership is all about managing the present, which we've got to do now. We're still in COVID, we're still taking care of patients and managing COVID at the same time and vaccinating at the same time. So leadership is managing the present. Leadership is also about selectively forgetting the past. What is it that we did that we should now just completely forget about? And leadership, at its very essence, in my view, is about creating the future. So as you ponder the discussions in all of your panels, we need to be asking ourselves, what's that new future? I think, quite frankly, and I'm an optimist, I think we have a wonderful opportunity now to create something better, to share as much knowledge as possible, but not be constrained by defining our world just because we work in a particular area. We're protective of our own silos, protective of our own discipline. We need a much more holistic view of what we need to be doing as we go forward. So with that, Peter, I will stop here and then turn it back to you guys so you can actually get to real work. Thank you so much.
Thank you so much, Mr. Dowling. Thank you for setting the stage for our two-day conference in such a meaningful way and for identifying the profound changes facing all of us who work in healthcare, and especially in the Guideline community. That was very insightful. We're very appreciative of your time. We hope you can stay around for the rest of the day, but we understand you have a very busy schedule. So in the interest of time, I am going to flash a quick screen about house rules, and then we're going to hand it over to panel one. Quickly, you've all been, you unmute yourself when you're called upon by a moderator. During the panel sessions, while our panelists are speaking, please submit your questions in the chat box. They will be conveyed to the speakers during the Q&A session ensuing every panel, and we will attempt to take short breaks after panel one and panel two. And as you may have noted, this conference is being recorded and the recording will be made available in a few days. So Sheila, I'm going to stop sharing as soon as you do your introductions so that Marlene could share. Sheila, go ahead.
Okay, great. Thank you, Yurato. Hello, everyone, and I'd like to welcome you to the first panel presentation. I'm Sheila McNair, and I'm moderating this panel, which is entitled An Unfamiliar Pandemic, Impact on the Frontline and Our Health Systems. During this difficult and often overwhelming year, we have lived through circumstances that few of us could have imagined. For this panel, we have asked our four panelists to speak from their experiences in the US, in Mexico, and in Canada to provide us with a platform for our discussions today that is firmly grounded in experience. In acknowledgement of what a difficult time this has been this year, I personally wish to thank the speakers for their willingness and their courage to share their experiences with us today. I will provide a very brief intro to each of our panelists, just as they are about to present. I'll be brief in order to maximize their speaking time. To the panelists, I will give you a verbal notice at the 10-minute mark, and that is a signal that you should bring your talk to a close. But you could take a minute to wind down if you feel that's necessary. So our first speaker is Dr. Marlene Mchugh, who is a clinician at Montefiore Medical Center in the Bronx in New York, and also an associate professor of nursing at Columbia University in New York City. So welcome, Marlene.
Thank you. I'm going to share my screen. doesn't seem to want to share now. Can one of you guys maybe pull it up?
Yes,
It's not sharing on my end.
absolutely.
So I think I'll begin we're waiting just to manage the time. So I just want to give you a little bit of a background. I'm going to be speaking today through the lens of a nurse practitioner. I'm a doctorally prepared nurse practitioner, and also through the lens of a nurse and my experience as an academic at Columbia University. So can I advance it? No, I think you're going to have to advance it. Okay. So we can move to the third slide. I'm sorry. So many of you know what has happened to us in the New York City arena. I work at Montefiore in the Bronx 3 days a week, and we were, the height of our surge in April 12th was about 2,000 patients within our healthcare system. March 13th, if you think about this timeline, we had 8 patients within the healthcare system. 325 we had deployed, and we had expanded our ICU capacity and moved to telehealth. So you can see in such a short period of time what a health system had to do and how they had to mobilize a workforce to do that. I want to go through a little bit about my inpatient and outpatient experience, and I really am highlighting the things that had jumped out to me looking back through this. We were hit with visitor restrictions early on. I work on a consult team 2 days inpatient working with primary teams, and our consult service went from inpatient e-consults to remote consults. Whatever we needed to do to balance and support the primary teams, we did. In New York State, we were really fortunate. I'm a nurse practitioner. Our scope of practice changed, and this helped us tremendously. We were able to now order home care orders to mobilize people through the system. We were able to, all healthcare institutions, even though the law is that nurse practitioners can sign for DNR, DNI, healthcare institutions move that forward across the board. Protocol development was so important. If you look back, we had protocols developed by March. CAPPS, the Center to Advance Palliative Care, had protocols developed that were available to people across the country in mid-March. And we focused on protocol developments that would help primary teams in symptom management, ventilator withdrawals, advanced care planning, and goals of care. Most of our goals of care was actually done over the telephone with families at this point. Video conferencing was done by whoever could do it with the family and the patient. It was done in the early part mostly by phone, but then progressed through to iPads for most teams. We did something at Montefiore that I think is was really brilliant and helped the ER teams tremendously. We had such a need for advanced care planning and goals of care conversations in the emergency room, and teams were so stressed. And nurse was put in one of the Montefiore health systems who had a strong experience in inpatient oncology and hospice. And she worked alongside the ER teams, the PAs and the attendings to help facilitate goals of care conversations early on prior to admission to the floor. The other thing that, besides all the stress that we lived through in the inpatient setting, one of the things that really sticks out to me over and over again is this constant auditory stimulation that teams were having. We were constantly hearing rapid response, code calls. We were leaving and going home to our homes in New York City and hearing the same thing in our apartments with the ambulances at night. So many of us had a really hard time shutting off from that inpatient and ER experience, and we had to develop ways to do that. One day a week, I spend outpatient doing palliative care in an oncology clinic. And this was one of the areas that I really look back and think I didn't plan appropriately for. So much of my focus was focused on inpatient management. We moved to telehealth very quickly. The goal was to manage and keep people out of the emergency room. But you can imagine a population who's frail, who's sick, the amount of ongoing connection that these patients needed to have was significant. The other thing I did not plan for was the amount of chronic and acute illnesses that you needed to manage telephonically. Ideally, we would have liked everybody to go to video telehealth visits, but that was not real in many of our cases. So a skill set to manage patients and their medical management by telephone was something that I had not planned for. We can go to the next slide. We can go to the next slide. In terms of the academic world, we were at Columbia very, very smart in terms of moving to a virtual platform 2 weeks before the surge happened. And I can tell you, being an academic clinical faculty member, I don't know that I could have survived without having this 2-week period of time to prepare. We had tremendous anxiety in our students trying to figure out how they were going to move forward and meet their requirements. And we needed to spend a lot of time in those 2 weeks before the surge happened preparing them. One of my memories of the last day of class, which was March 9th, was students, a 50 class room, students asking, did I think this was really going to happen? And I remember having to stand up there and say, yes, you need to prepare in the next 2 weeks because this is going to be a part of your life that is going to change you forever. But preparation was crucial. And I had not been as firm in an academic setting as I was that day with the students. The other interesting piece was the students had no idea who to follow. Dr. Fauci was something that many of them had never heard of. So focusing them on how to follow, how they needed to prepare, and following the signs for the future was important. We can go to the next slide. Personal, how we lived our lives. We saw the news from Italy and we were terrified. And we knew we had 2 weeks. And we knew we had 2 weeks to prepare. We didn't understand the level of contagion. Nobody did. We didn't understand what this meant, the period of time in rooms, masks, blah, 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 blah. So the fear in those early days, I think anybody in the clinical arena can testify how significant this was. There was grave concerns about PPE supply. There was concerns about personal and family exposure. And early on at Montefiore, we saw deaths of our colleagues. And that was very, very traumatic for many of us. Our daily routines became very, very focused. We knew every day what we needed to do. We needed to monitor our temperature, look for symptoms. We needed to find support, and however that support, we needed to find it. It happened in all different ways for everyone. One of the things that I think when I look back that was really, really helpful is I'm part of a hospice and palliative care nursing group across the city. And we had virtual meetings every few weeks. And this brought together a group of nurse practitioners and nurses working across the city, sharing their fears, talking about what was working, talking about what wasn't working. And this was a way for us all to support each other and get together. We needed to manage our family life. I can tell you one of the most stressful things is I have an 89-year-old mother who depends on her family, and how to figure that out when you're a healthcare worker was really, really important. I don't think any of us figured that out until a few weeks into this, but it's something that we need to prepare staff for the future. We need to develop some type of personal stress management for ourselves. And I think that is something that we need to focus on early on, and teaching people to look at what works for them, mindfulness, tapes. For myself, I would watch Netflix when I would come home. Everyone had different things that they did. Next slide. Montefiore really did a remarkable job when I look back at this. This was such a quick, rapid mobilization. The ability to mobilize the academic teams, academic leverage, move people from within the medical school, faculty into clinical settings, deciding whether people needed to be inpatient, outpatient, how everyone could contribute. This was all hands on deck. Everyone needed this broad scope of practice. So for many people, this was a challenge. They might not have a comfort level with a broad scope of practice. So they may have assumed a different level on a team where they had been a very high functioning, nurse practitioner or attending physician, but depending on what their comfort level is, they move to a different area. People needed role flexibility, and this is very important. And I speak to this from a nurse practitioner standpoint. Nurse practitioners many times are focused in silos, outpatient, inpatient. We need to think about flexibility early on for the next, whatever we go through next. But role flexibility is important, and we really need to be encouraging staff early on that they may need to be involved in flexing.
Marlene, this is Sheila, that's 10. Thank you.
Okay, so I'm just going to go to the next piece. The one piece about family medicine that I think is very, very important is there is a slide in the set that talks about what Montefiore did in terms of family practice. And the family practice team mobilized, went from 2 teams to 6 teams within a 2-week period. They moved inpatient, outpatient, depending on what the health needs of the practitioners were. This was significant when you look at how teams could mobilize and care for patients, such a large number so quickly. There's an article that's actually in the press that's going to come out soon, talking about how an inpatient family medicine and outpatient family medicine medical directors mobilize teams to increase access to care for hospitalized patients. And if I have one more minute, talk.
I can give you 30 seconds.
Perfect. Daily communication, daily clinical updates, system-wide updates, treatment guidelines and advisories, communication, leadership on the front line, leaders walking alongside of the troops. This all made a difference to us. We were so stressed. There was so much chaos. Streamline, organization, structure, helped the personal chaos that we felt within us, and it helped us do our jobs every day. So looking forward to what you need to think about for the future is standardized communication. Caregiver Center, Montefiore did a brilliant thing. We have caregiver centers in each of our hospitals. Those centers which support families were moved over to support staff. They were open till 7 o'clock every night and staffed by social workers. We would go in there, and that's where any times where we would get our support. Support your team. We had GoFundMe to support teams for transportation support, meal support. You gotta feed your teams. Support for families. Montefiore did a wonderful thing with the Robin Hood Foundation, working with providing financial relief to families who had lost a loved one to COVID. So if anyone's interested in that, you can pull up that site at the bottom. I talked about that: leadership, structure, support, and clear communication.
Thank you, Maureen.
Okay.
Thank you. Sorry, but I have to.
I know it's a lot. Quick.
We'll get back to some of the. Maybe we can pick up on some stuff in the Q&A session. But thank you very much. So our next speaker is Dr. Jose Luis Mayorga, an otolaryngologist and adjunct professor of pediatric otolaryngology at the National Institute of Pediatrics in Mexico City, Mexico. Thank you and welcome, Dr. Mayorga.
Hello, everybody. First of all, I would like to thank GE North America to invited me to be part of the organizational committee to be here in this great conference, talking with you. I'm very honored to do that.
A little bit louder if you can, Jose Luis.
Thank you. Yes. I'm sharing my.
Perfect. If you could put it in the slide mode. Perfect.
Okay.
Thank you.
So we would like to share some things that we happened in Mexico with facing a new pandemic. I want to speak some things about our health system prior to the pandemic, and then when we knew that this was coming, that it was very scared, because we knew that we don't have a very strong health system, so we have a lot of work to do with this. This is my university in Mexico City. We know that the usual clinical decision making is very difficult, facing a lot of complicated diseases. But we have a lot of information. We have a lot of data, a lot of evidence from clinical trials, and this is a difficult task. It's a contextual, continuous, and evolving process with a lot of factors we have to take in account to make better decisions. Our health system in Mexico is considered in transition by the North American Observatory of Health Systems. We have more than 124 million residents, 27% under the age of 15, and only 7% who are 65 years or older. We have a very big issue about income inequality. We are one of the biggest income inequality in OECD countries. We have a very high prevalence of diabetes. We have very high prevalence of hypertension, obesity, and other chronic diseases. And only 14% of the population have social security or private insurance. So we have a lot of people that don't have any kind of medical insurance, any kind of medical services, and it's a very big challenge amid a pandemic. Mexican health system works in three different and interactive systems working in parallel. The first one is employment-based social insurance. The second one, public assistance services for the union supported people, people that doesn't have a formal job, that are working in markets, that are working as taxi drivers maybe, that they don't have a formal insurance system, and a private sector that is the less important one in volume, that is composed of service providers, insurers, pharmaceuticals, health providers. We have a big area of opportunity in total health expenditure in Mexico. As a share of GDP was 5.7% in 2015. It is considerably lower than the OECD average. Out-of-pocket spending continues to be a major source. And if we talk about that in the middle of the pandemic, a lot of people spent most of the money that their savings to face a familiar in the hospital, in the ICU units. And it's very expensive to be hospitalized for COVID-19, and they lost most of their savings doing that. So we have a very weak health system, and then we face this.
To come, Dr. Fauci? Yes, it is. Can you elaborate? Well, whenever you have an outbreak, that you can start seeing community spread, which means by definition that you don't know what the index case is, and the way you can approach it is by contact tracing. When you have enough of that, then it becomes a situation where you're not going to be able to effectively and efficiently contain it, mitigate within our own country. Bottom line, it's going to get worse. There are now more.
So we could see that we are going to face a very difficult times in challenging times to manage a pandemic in Mexico. The Ministry of Health strategy is centered in epidemiological surveillance. They didn't want to make a lot of tests in Mexico. They felt that that wasn't going to be a good solution for Mexico. They try instead to put the people in Mexico on self-isolation, social distancing according to the pandemic phases, closure of non-essential activities, closure of schools since the very beginning of the pandemic. They work hard increasing the hospital's capacity and resources because they knew that we have big issues on that regard. A lot of inequality in Mexico, a lot of lack of access to good medical services, not in the big cities, maybe in the rural regions, and that would be very difficult to face the pandemic. Not border closure of massive tests were one of the strategies. And the main objectives for the government in Mexico was to reach a flat curve of cases and avoid overwhelming of hospital occupancy and resources, and to maintain a balance between economic activities and surge in COVID cases and mortality. They provided a traffic light monitoring system for epidemiological risk of COVID-19, implemented in all the cities and implemented in all the states of the country. So every state announced every week what was the state of the pandemic in that region in particular. So they used this system in order to make guidance to all the economic activities. If the light was green, all activities, including school activities, are allowed. That was happened only in the beginning of the pandemic, and after that, most of the time we were in orange or red. The red light was about only essential economic activities will be allowed, and people will be limited to move outside their homes during the day. So that was in general the most important strategies implemented by the government in Mexico. What happened in the hospitals in the country? Most of the hospitals, the main hospitals like the National Institute of Respiratory Diseases, Professor Juan Carlos is going to talk about that later, transformed in COVID patients. They only received COVID patients, and they didn't receive any other patient or different disease to manage. The hospital suffered a deep restructuring. The restructuring of the hospitalization areas. The human resources were allocated in triage and intensive care. We could see orthopedic surgeons in the COVID areas, in the UC units, people from all kinds of specialties working together in the management and taking care of the patient of COVID. The protection equipment for healthcare workers and hospital supplies, I put that in red because most of the criticism that the government receives in these few months were from the healthcare workers. We didn't feel we have enough protection equipment during the pandemic. We could see a lot of healthcare workers get sick of COVID. Some of them died because of that. Very sad situation, and I think that it was the most important criticism to the Ministry of Health because of that.
Jose, Luis, sorry, this is Sheila. You're at 10 minutes.
Thank you. We have staff training, identification of cases and contacts, and social communication. My hospital wasn't COVID, but we have to see all other diseases and all other causes of urgent attention in not COVID patients. The first thing I did because I knew that the government was not going to give us the personal protection, was to buy it in Amazon for my fellow residents and for me, for myself, in order that they feel safe working and seeing the patients. We could see a flat curve in the first days, in the first months of the pandemic, but we could see a very important surge of cases at the end of the year and the first months of the year. We could see more than 20,000 new cases every day in December and January. And that's because the gathering of the people in the holidays season, all the people got together in holidays, and we could see a very important surge of cases, a lot of accumulated, a lot of deaths and hospitalization, and the hospitals were very close to be totally saturated because of that. I only want to say that something is still missing. We don't have enough quality evidence. We could see that this pyramid that we used to see with a lot of data, a lot of guidance from different institutions, we don't have any of that in the middle of the pandemic. So we have a lot of areas of opportunity to working on that. I will skip some.
Yeah, we're actually out of time now.
Yes, and I only want to say that we have to work in strained collaboration between countries, to strain a collaboration between communities that are generating evidence, clinical trials, systematic reviews, and clinical guidelines to work together on facing future pandemics in the near future. And well, that's one beautiful photo from the people that was working in the pandemic in my city. Thank you very much.
Thank you very much. I'm sorry that we're so constrained by time, but we have a long program and 2 more panels of which you are aware.
Yes, I know.
Yeah. So thank you, Jose Luis. And I'd like to do a brief introduction. Our third speaker is Dr. Ed Su, an assistant professor of emergency medicine at Columbia University and medical director at New York Presbyterian Allen Hospital Emergency Department in New York City. Welcome, Ed.
Thank you. Thank you for the introduction. As Sheila's mentioned, I'm working in the emergency department at Columbia University, and I want to speak a little bit from a perspective of a clinician who was working through that first surge back in March of 2020, more than sort of my administrative or operational role as at that time assistant medical director and now medical director of the Allen Hospital Emergency Department. However, another one of my roles at Columbia is as a leader on a committee that creates and adapts guidelines and best practices as local pathways or care guides. And it was that sort of intersection where I really thought I might have some experience to share with this group. So disclosures, I have no financial conflicts of interest. I titled the slideshow here 21 days. It was a reference to a zombie movie, 28 Days Later. If any of you guys have seen that, it's about, I think it's almost 20 years old now. Unlike that Danny Boyle movie, that I don't think there was any episodes of cannibalism caused by COVID-19, but it seemed to cause a lot of other sorts of mayhem. What we experienced in New York City was a real precipitous increase in cases, which really led to a quick evolution of from a sort of a distant or theoretical threat into a true disaster. And as sort of the stakes got higher, actually what we found was sort of the clinical uncertainty increased, even though we were gaining some more experience with the disease. And when it came to making recommendations to our teams for clinical management, we really had to rely on the best information available, which really was of a mixed quality, as all of you know. I don't know if any of you read the New York Times, but this was a headline that came out, or an article that came out on March 13th. Seeking advice on the coronavirus, Jared Kushner enlists a doctor in the family, and the writers went on to detail how this physician, who is an emergency medicine physician actually somewhere else in New York, was giving advice to Mr. Kushner based on feedback he was eliciting from a Facebook group that he was part of, some big, I think several thousand member a Facebook group of mostly ER physicians. And he was soliciting their sort of input on how the government should respond to the COVID crisis. And I think the sort of tenor of the article was sort of in a negative direction, but 5 days later, actually one of my colleagues at Columbia published this article in the New York Times at the front lines of coronavirus turning to social media, detailing how she, as well as I think if you ask a lot of clinicians, many of us, or if not all of us, were using social media as a major source of actually gathering information that we would later actually use in clinical practice. So my idea was to sort of give a brief sort of picture of what it was like sort of descending into the COVID surge. March 1st was actually the first coronavirus COVID-19 case diagnosed at my hospital, New York Presbyterian Hospital, but the crisis really didn't hit home until 3 days later on March 4th, when a planned bowling outing was canceled as a precautionary measure because of the potential for hosting a super spreader event. And that's really what it really hit home, although by that point, we had not diagnosed any cases in the emergency department, nor actually at that time was there any capacity to do so. The very next day, we started to have a series of virtual huddles with the emergency department physicians and physician assistants. And this data comes from the Greater New York Hospital Association tracker, but this was a number of COVID-like illnesses that were flagged on those days in the two hospitals that represent that Columbia University staffs, the Milstein Hospital and the Allen Hospital Emergency Department. So 50 to 70 cases of COVID-like illness, which encompass influenza as well. And we were at the tail end of an influenza season. March 9th, a few days later, was the first patient that came through our ED that we later found had COVID. There was actually a delay of a couple of days until we were aware of this, because at this point, testing for COVID was still restricted mostly to patients who had clear exposure to a known COVID contact or travel to a COVID-affected country. This led to quarantine of, I believe it was 7 staff members, and that's when we realized that this was going to be a really large problem. At that time, the hospital had been working on acquiring some local testing capacity, and March 11th, we were able to first do some PCR testing on campus. And from that point on, we saw an explosion of cases as we were able to start testing patients who we had previously only suspected may have COVID. And as you can see, at that point, we had over 100 COVID-like illness visits on that day. Within a few days, it was clear that we were seeing a wave of arrivals. We were seeing over 120 arrivals a day of COVID-like illness, and the hospital opened the first of several sort of diversion resources, clinics and tents to accommodate ambulatory patients who presented to the ED with possible COVID-like illness. We did see a little bit of a dip because of those cough and cold clinics, but despite that, within 3 days, we had already hit over 175 arrivals at the 2 sites combined. At this point, a new regulation came down that there was no mandatory quarantine for asymptomatic healthcare workers based on the tremendous number of our staff who had been going out on quarantine over the past week or so. That day, on March 17th, the EDs diagnosed 29 PCR positive COVID patients. And remember, we were only able to test patients who were being admitted as opposed to the majority of patients who were still being discharged. 2 days later, that number was 39 PCR positive patients. And at that point, we had the first meeting of a New York Presbyterian hospital system-wide COVID pathway committee, of which I took part. Citywide on that date, there were 3,954 diagnosed cases and 26 deaths. Over the next few days, while our committee did its work, that number would jump to 20,000 cases and 208 cases. And you can see that in terms of COVID-like illness presenting to the emergency department, we were already over 275 cases by that point. On that day, March 25th, we had 84 PCR positive patients, again, representing only a fraction of the patients who likely had COVID. We had clearly begun to come into disaster conditions in various sort of aspects of care. And that was the date we were able to release our first COVID clinical guideline. One sort of pithy definition of disaster I've heard is a disaster is when local needs outstrip local resources. And that's certainly what we had begun to experience at the end of 21 days after this sort of crisis started to hit our shores. A lot of the conversation up to this point had been about rationing and resource allocation. We talked about ventilators, PPE, and ICU beds. But by March 25th, well, it was clear that we were actually running out of all sorts of different things: oxygen tanks, oxygen regulators, infusion pumps, even sedation medications for patients, for the many ICU patients who were boarding in the EDs, physical space, and staff, as so many staff went out on quarantine. And that time of crisis really heightened clinicians' need for guidance. When the first few cases were being diagnosed, there were clinical questions about the care, which patients would have COVID, what their prognosis would be, what treatments should be initiated, what diagnostic tests should be performed. But when it was limited to 1, 2, even a handful of cases, it was easy for clinicians to take the mindset of, well, we're just going to do everything we can and treat every case very seriously. When we were hitting true surge conditions, all these questions still existed, but now we had resource questions as well. How many patients could the hospital really admit? Were there patients who the risk was so low that, or so high that they would need to be admitted to the hospital, or did they just have to be discharged? Would doing workup or treatment or initiating treatment on this patient make it harder for other patients to receive treatment? How would we allocate care, not life-saving care, right, which was on people's minds, but what comes before that, non-life-saving sort of daily medical care? And so I think clinicians in my community really felt a need for guidance. If you work with clinicians, I don't think you probably hear them ask for guidelines that often. Usually clinicians think they know what they're doing, but on one of the Facebook groups I was a part of, an actual ER doc posted in all caps, "We need guidelines," speaking to sort of the mental state at that time.
And sorry, this is Sheila. We're actually at about 10 and a half minutes now. Thank you.
So our group that convened to try to establish clinical practice guidelines, we found that the typical sources of knowledge were fairly lacking at that time. And instead, we had to rely a lot on what we could gather from these more atypical sources of knowledge, a lot of social media and interaction with our peers who are on the front lines and kind of trying to understand what they were thinking and seeing. I don't know if you guys remember the CEO, I think, of Alibaba. He published some guidelines that they had developed in China that were translated into English. One document that became critical for us actually was this Italian, an official society guideline, but one that someone used Google Translate to translate into English and posted actually on our academic society website. So it was sources like that that really kind of became the basis for our initial sort of attempts at making some clinical standardization and clinical guidelines that were appropriate for a crisis situation. And it was really crisis care that we were engaged in. As you know, case counts continue to rise over the next several weeks. And despite a remarkable job in terms of expanding capacity on the hospital and lots of mitigation efforts, there was still unprecedented amount of ED crowding and patient load. And as we know, a formal crisis standard of care declaration was never made. Thank you.
Thank you very much, Ed. Our next and final speaker for the first panel is Dr. Doris Grinspun, who is the CEO of the Registered Nurses Association of Ontario, Canada, an organization that represents nurses and also develops guidelines. So welcome, Doris.
Thank you. Let me give a bit of background, and I think it's very appropriate that I'm the last speaker, as I will build on some of the issues that my colleagues have presented before, with some caveats. The benefits of Canada's health system, universal. The commonalities with my colleagues, the unknowns. The commonalities with my colleagues, which I will point out what we knew, but we didn't act on. The issue of vulnerable populations that Dr. Crowley spoke before, and the issue of calm versus voice. And let me put with that public that I am the very honored recipient of the American Academy of Nurses Courage Award during COVID. So that explains a bit already the calm versus voice. I had the privilege to be involved in all the committees, or many of the government committees, but yet we are independent. We are talking about the province of Ontario, 13.6 million people, and in a country of 38 million people. Let me tell you, there is no doubt that there is a benefit when a government is unified and all government levels, provincial, federal, and local, work in unison. Which I believe in the US would have happened if you would have had President Biden. It didn't happen though with President Trump. And there is a benefit to universal care, as Dr. Mayorga was speaking, the challenges in Mexico that happened. And I would love to discuss with you about some other challenges with President López Obrador in your country related to this. I certify that I have no conflict of interest, the only one, that I'm the CEO of RNO. And with that, I am saying, not because it's a conflict, but because we do have as one of our major pillars of work, not only healthy public policy, but we do have the largest entity of best practice guidelines used in nursing in Mexico and in all the countries actually that have been participating, and 1,000 organizations around the world. I am saying that because not only we use the guidelines during the pandemic, and you will see how, but we also continue to develop the guidelines. I think Dr. Crowley spoke very eloquently about how do you maintain an organization moving forward. And I think that is an area that in any crisis at RNO, we have done always very well. We are very good at segmenting out what's the crisis, and a group of us works on the crisis, and the rest of the organization continues to flow as if nothing really is happening. So in the midst of this pandemic, we developed an issue, new guidelines related to topics nothing to do with COVID, but that are good for patients in general, so that we don't look after in the back mirror and say, oh my gosh, so much catching up. Nonetheless, you have a situation that I got involved actually already in January, and you will see. But just to give you a sense, compared to the US, we are not as dramatic as the US or Mexico, but we did go from 89,000 to almost 1 million people between May and March. We did have the same issues as many of you had, of PPE and the lack of PPE. Oops, it's going by itself now. Okay, the PPE and the lack of PPE. Despite that, we all knew, because I actually was in touch with Italy because of our work on guidelines, with Spain because of our work on guidelines, and with others, and with China. And our government simply, and so did yours at the beginning, kept saying low risk, low risk, low risk. Well, some of us knew that nothing of this was low risk. We raised the alarm bell, you can see there, on January 20, we were in the newspapers saying that we are putting people at risk already in Canada and in Ontario by not taking action on what was happening in Juan. We were in the media from January to this day over 3,000 times in the media, television, radio. We have become the source of giving what's coming ahead, not only looking at the back mirror. And that is very important, because we kept urging government that we needed to follow the precautionary principle. And if you look at the report that Adrienne did during SARS, called SARS Unmasked, you will think that the recommendations in that report are recommendations about today, but no, those were about SARS. So with all due respect to people that say we didn't know better, yes, we did. We did, but we did not take action. In terms of PPE, that we should have been better prepared. In terms of the issues of isolation, in terms of the issue of lockdowns, et cetera, et cetera, et cetera. And later on, of course, Dr. Tedros said, guys, you need to do better, to all of us in the world. And even then, we still kept questioning. You may remember that Boris Yeltsin at the beginning said it will be herd immunity. Of course, that was not the case. And then was catching up time. I do think we need to do better on that. Very soon at the beginning of the pandemic, I would say February already, we launched a portal. So not only nurses, millions of people from all over the world visited the portal. The portal had to do with anything from what we knew from the science, what we knew that was happening with vulnerable populations, documents that we developed about what needs to happen and what needed to happen with long-term care was a big focus of us. People living in shelters, people under house, that was a big focus on us. And then alongside with that, we did at the beginning very much a cheering up of healthcare workers, simply to give them the strength to endure what was going on. So all that was and is still in the portal. I launched a blog also very early on that was daily sent to everybody. Now it's done to this day weekly. So the program on guideline development and how it came to play and help during the pandemic. First of all, I already mentioned to you that the organization continued to develop guidelines. In fact, we issued 2 new guidelines during the pandemic, the one on incontinence, not related, of course, to the pandemic, but is part of our ongoing work. And also we continue to implement guidelines, and you will see some inspiring launches during COVID of best practice spotlight organizations in various parts of the world. For that, Ontario had launched before the pandemic a new model of integrated systems of care called Ontario Health Teams, where you have all the sectors, very much like the HMOs in the US, not-for-profit HMOs, because that's the system in Canada. And we actually worked with 4 of those so-called HMOs during the entire pandemic in the evidence-based practice and on the staff engagement to bring some sense of unity and some sense of stability to their work, while they were working very much on the guidelines and the directives from a central place, the Ministry of Health and the Science Table related to COVID. We were working with them on the guideline on person and family-centered care. So that really, that would become a focus during the pandemic, and people, very much like Dr. Crowley said, will not feel lost in the middle of this chaos. The guideline on person and family-centered care was implemented across many of the 1,000 best BPSOs that we have, but in particular across those 4 Ontario health teams of integrated models of care. It has been a success story of mega proportions, as defined by their own patients and as defined by their staff. We use 2 models, 2 frameworks to implement guidelines, and that is ongoing. The first is the knowledge to action framework that you are likely all very familiar. The other one, which there will be a session tomorrow in the open sessions, is the social movement action framework. This framework that began its work before the pandemic continued during the pandemic to develop the framework and is being launched for user tested as we speak. And tomorrow you will have the possibility to attend one of those sessions at 3 p.m. that will be exactly on the social movement action framework and how do we use social movement to actually encourage uptake of evidence and sustainability of evidence, and how did we use it during the pandemic to create this sense of togetherness that people were feeling so much in crisis, but this brought a tremendous sense of relief to them. This is during the pandemic, September 10, we had the 4 Ontario health teams meet together in Zoom with Zoom rooms, doing all kinds of exercises on social movement, and again, focusing on how they were using the person-family-centered care during this difficult period with their patients across their organizations. And you're talking dozens and dozens of organizations because each one of these Ontario health teams has anywhere between 10 to 45 organizations. Also during the pandemic, October 13, we launched a new VPSO in Chile, Hospital El Trabajador. And this is important because they didn't have time to wait for us. They did not want to wait till after the pandemic. They already had started to use our guidelines during the pandemic for pressure injuries, for prevention of falls, for person-centered care, for transitions of care. And they basically stood up and demanded that we take them as a VPSO and we launch the VPSO, which we did, as you can see there, October 13. Not only that happened.
Doris, sorry, this is Sheila. Just 30 seconds, okay?
I am finishing.
Thank you.
You have the slide, so you should be able to see I'm finishing.
Okay.
Not only we launched the Hospital El Trabajador in Chile, the government of Chile, the federal government, MinSal, launched just recently, last week, 15 additional hospitals during the pandemic. Again, they already had 7 hospitals that are best practice spotlight organizations, and they saw the difference that the guidelines already was making in their patients and in their staff because of also not only the evidence uptake, but the staff engagement. And they decided to launch 15 additional hospitals for which they engaged in selecting those hospitals. And we just did the training last week. So expanding in the middle of a pandemic is possible. The program, that's the Minister of Health in Chile on the left, that is me smiling out of joy, seeing the training and how it went. And those pictures that you see here in the bottom are pictures that we use to draw attention to social movement during the Zoom sessions using the rooms. If any of you are interested in joining the program, I will give you in a second the link. I told you that at the beginning we did Cheer Up for healthcare workers. This expanded across the entire country. It also expanded to other places. And then on March 11, because of the year, we did again a Zoom with tons of people together to mark the 1-year anniversary from COVID. So the message is, some things we didn't know, many things we knew, we could have done better, and it's important we acknowledge. Let's at least learn for the next time so we don't say we didn't know. And also, let's make sure that our organizations do not become paralyzed by a pandemic, because as Dr. Crowley said, there will be other things to come. So we need to learn how to continue to run an organization so that we continue with the work of guidelines, implementation of guidelines, and because they bring stability to people, they bring togetherness to people, and that is very important. Should you want to join the VPSO program or any of the aspects that we do with guidelines, that's my contact. PG is my right hand. In fact, she did the training with me in Chile. So by all means, would love to hear from you. And as I said, tomorrow there will be a session on the social movement framework for guideline for implementation science.
Thank you very much, Doris.
Thank you.
Thank you. And thank you to all the panelists. So I'd like to ask Maria, who's been monitoring the chat, do you have any questions there?
We do. I'll start with a question from Craig Robbins. Similar to what Ed shared for Marlene and Jose Luis, policies or care protocols for your institutions, and what information or specific resources were used to inform and update those policies or protocols? Maybe we'll start with Marlene.
So policies and protocols were updated through the department chairs, and they were, really based on evidence-based medicine that individuals from the departments were reviewing on a daily basis. There was a portal that was accessible for all the healthcare providers, and evidence-based guidelines were disseminated through my department, which is under family medicine, every day to the teams. So that responsibility was by the chair and the vice chair, mostly came through medicine and through family medicine. Montefiore, we also had a command center that I didn't get to mention that managed a lot of the dissemination of information, and that was under critical care medicine and infectious disease. So it was organized and delivered throughout departments on a daily basis.
The same thing in Mexico. We could see an avalanche of documents generated abroad our country, in Europe mainly, that I think that they have the most cases at the very beginning of the pandemic. The different departments of different specialties deliver some documents, many of them experience-based, but they were very useful.
If I can add, Sheila, we had the benefit of having a very centralized approach because of the science table, and the Ministry of Health basically sent the protocol, so they were all the same. But still there were issues of interpretation of protocols, what tools to use to implement some of these. So we actually developed a lot of tools, for example, for nurse practitioners in long-term care, etc. They're all posted in the blog, by the way. We also created a Facebook in the portal that nurse practitioners could share one with another, and also we did one for families, for family members.
Thank you. And PG put the links to a couple of those things in the chat for those of you interested. Question for Dr. Suh. Are you and your colleagues using any specific tools to call social media for certain topics? And are you using the social media info in any kind of correlations with some of the other types of data you presented, in addition to informing guidelines, as you explained?
No, unfortunately, we didn't have any sort of special tools to sort of pull from social media. I imagine that some might be available for Twitter, although I think for Facebook, a lot of the information that's that are in private groups are sort of private and not accessible. That was the social media part was really what we found ourselves doing sort of at the initial sort of phase as the crisis was ramping up. I see Xiaomei, for example, asked if we had seen that particular guideline that was written based out of the sort of the early experience in China. We found that the few guidelines that were available weren't really addressing the kind of questions that we were experiencing as surge conditions developed. They were sort of more written from a perspective of, a controlled situation, a controlled epidemiology rather. We did find a lot of sort of information and anecdote on social media, some of which was useful, some of which honestly wasn't useful. And that was another problem. Actually, Dr. Wire put this into the chat. it was basically impossible, right, for us to sort out, if somebody saying on Facebook that, well, I've seen 10 patients and they presented like this, whether that was meaningful data for us to use or not. So the social media part, it was sort of a double-edged sword, and there was just as much information as misinformation. But it did lead us to things like the Italian COVID guideline, which we found enormously helpful because it helped us understand how they were risk stratifying in sort of those really hard-hit towns in northern Italy, which really, it seems like the New York experience kind of followed behind.
Just kind of a quick follow-on question. How did you overcome Facebook fact checkers that removed posts of emerging evidence and debate? Or did you run into that at all?
Yeah, at the initial phase, I don't think it was Facebook that was doing much fact checking, at least in the groups I was, sort of on. Later, I mean, the group moderators actually tried to do some moderation themselves, but sometimes that really did seem counterproductive in the sense that certain things became, I believe they became politicized sort of earlier than necessary. When the data was still sort of unclear, there did, because it's social media, there was sort of a groupthink dynamic that developed. But that was really sort of in the initial phase in March when there was still a lot in the published literature, but it was little enough that we could do a literature search and pretty much consume all of the literature. Since that point, obviously there's been an explosion in publications, which also have been of variable quality.
Thanks. And Marlene also put a link in the chat on it looks like a news story on the front lines at Montefiore for those interested. Okay.
I have a question, Maria, if you want me to go ahead.
Sure, go ahead.
Okay, so it's sort of a personal question, and we've all been through this, and maybe we don't really want to look back, and I certainly wasn't in your situations, but it's kind of a two-parter. How did you get up and go to work in the morning, and what did you find that you think we should be doing now that would help in future disaster scenarios? So Marlene, maybe. Okay.
And I would like to comment too at some point.
Okay.
I think it's very important that we talk about this early on in education. And I think it's very important that we talk about how to develop resilience and how to develop skills for yourself. I know for personally myself, I had to shut off because I had to go back. And I found for myself, I needed to totally zone out and watch Netflix. And I had to watch things that were completely separate from what I was seeing on an everyday basis. But in saying this, I think that it's really important to get clinical people together to talk about what the workforce needs to have part early on in terms of their education, because we are going to see this again. Resilience and flexibility, moving across settings, all these things are so important. So early on, I think we need to be having these discussions, and we need to find out what worked for clinicians. And I also think that I would never think that I would go to a support group of my colleagues on Zoom across the city. But you know what? That's what worked for me at that point.
Yeah, I want to add to Marlene's comment. We are about to issue, in fact, in my last blog, you can already see the preliminary results. In Ontario, we had 2 nurses that committed suicide. Let's start with that. And in Quebec, they were 3 physicians. It shocked us. That's number one. It shocked us when one had no history of anything. And we started several months ago. I thought we had a good pulse on everybody because we kept talking with people. But we started these heart-to-heart conversations, Marlene, you're talking about, and tons of people coming to talk. And what Marlene said, some saying, I need to shut myself off it because I can't, and others telling you I can't get away from it. I can't get away from it because they finish working, they come home, they put the television, what do they see? COVID. It's COVID everywhere. COVID, people are COVID out. And I don't know about the US, but in Canada and in much of the world, there is a push and pull. There is a huge increase on people that want to become nurses. So there is an explosion in Canada and we are pushing for a higher enrollment. And there is also, there will be a bigger attrition than ever before. So, you know, some people simply had it.
Yeah. Oh, Jose or Ed, would you like to weigh in on this? Go ahead. Who?
Don't have anything to share.
Oh, okay.
For me personally, you know, as a person of faith, that was an important part of my experience, especially that first part with the surge and the disaster conditions. And I think, you know, sort of, it did highlight for me how sort of the human element of what we do as medical professionals is really important. And you know, despite the maybe not despite, but you know, that doesn't conflict in my mind with the focus on science, right? We should follow the science and try to make sure that we're accurate and rational and reasonable with sort of our medical and clinical decision makings. But to understand that it seems like, you know, being human is more than just being a biological creature, I think was important for me.
Thank you. So with that, I think I have to close. It's 2:47. We've gone over a bit. Jose's heading the next panel, so we'll hand it over. And I'd just like to thank everybody, all the panelists and all the people who submitted questions. So thank you very much.
So thank you so much for moderating, Sheila. Thank you, Drs. Mayorga, Mchugh, and Grinspun. That was so insightful. And thank you for sharing your personal stories, sort of reliving that we all experienced the first few months of the pandemic and as it continues today. So we had scheduled a 10-minute break, but in the interest of time, and since we're running a little bit behind schedule, I think we're going to skip the break for this session and move on to panel 2 immediately. Feel free to step away from your computer if you need to a few seconds, but we hope you come right back. But we'll take about 30 seconds to transition in case you want to stand up and stretch your legs. But Jose, let's wait like 20 seconds longer and then start with your introduction of panel 2. And that'd be great. And in the interim, the panel 2 speakers, if you could turn on your video so that I could spotlight you, that would be great. Thank you so much.
Thank you, Yurada.
Jose, I think you can get started. Dr. Gupta is on the call, and when his video is available, I will also spotlight him. Thank you.
Okay, so we are going to start the panel number 2. Hello again, I'm Dr. Jose Luis Mayorga from the National Institute of Pediatrics in Mexico, part of the Master in Science program in in the National University. I am happy to be your moderator for panel 2. In this session, we are going to hear from our esteemed colleagues from Kaiser Permanente in the United States, the National Institute for Respiratory Disease in Mexico, the Canadian Thoracic Society's Respiratory Guidelines Committee, and Cochrane, Canada, who are going to share with us their perspective on how healthcare providers and the guideline community responded to the challenge of COVID-19. We hope the diverse experiences and reactions shared will provide the opportunities for us to not only connect, but also to identify opportunities and learnings for our own communities to incorporate as we continue to face this pandemic. Our first speaker is Dr. Craig Robbins, a GENE Board of Trustees member, but on this panel representing Kaiser Permanente, where he heads the National Guideline Program. Please, Craig.
Thank you, Jose. All right, let me share my screen. All right. So thank you everyone for attending today. It's really my pleasure to join the group and participate on this panel. I want to spend some time here sharing with you our experience at Kaiser Permanente related to evidence and guidance in the face of the COVID pandemic. I don't have anything to disclose. Again, I'm just going to be sharing our experience here throughout the past year. So many people are probably familiar with Kaiser Permanente. For those who aren't, you can see on this map where we're located in the US. Our largest presence is along the West Coast from Washington and Oregon and California. Across the whole program, we have 12.5 million members, we have over 23,000 physicians, 63,000 nurses, and 200,000 employees. We operate in 50 markets in the US and a very large organization in terms of our finances with an operating revenue that's very high. And you can learn more about us at kp.org, who we are if you're interested. For many years, we've had a KP National Guideline Program, and we have covered many common topics related to population health and kind of quality topics, very common primary care things like you can see here. And we've been, involved in the Guidelines International Network since 2010, and we've been following the GRADE methodology and our formal guideline development work since 2011. But I have to acknowledge that as COVID started, we had to largely put this work on the back burner, and we really had to move from formal grade evaluation of evidence to really just developing guidance, and we had to do that pretty quickly, kind of overnight, if you will. So I want to talk a little bit about how we did that. Our overall structure for trying to address the COVID pandemic in Kaiser Permanente was that we immediately set up something called a National Command Center, or an NCC. The example I'm showing here really relates to a program that we instituted under the National Command Center in the last several months as the vaccines for COVID became, more in the forefront and became an option for us to really attack the pandemic. But the structure of the National Command Center went up immediately. It went up a year ago, like February into March, and that involved executive leadership across our program. It involved leaders from all of those different regions that you saw in the state of the US. It involved physicians, it involved nurses, and it involved pharmacy leaders to try to help everybody stay aligned and stay on the same page. Some decisions were made at the national level, but a lot of things in our program have to be kind of tailored for local implementation. But this was the structure that got put in place. And then we pretty quickly stood up some interregional clinical expert groups that we knew we were going to have to rely on throughout the pandemic. We had an expert group on infectious diseases, and there were representatives, physician representatives from each of the regions. We've had one in pulmonology and critical care as well. And early on in the pandemic, for the first 2 or 3 months, the infectious diseases specialists were meeting a couple of times a week, and our pulmonary and critical care medicine folks were meeting at least once a week to compare notes. So at Kaiser Permanente's Care Management Institute, we try to organize our thinking and approaching things around what we consider to be clinical knowledge integration, that we really are trying to understand the best evidence we have to work with, try to help develop guidance and then disseminate it so that people can use it. And we kept that thought in mind, that we didn't have the time, as many people have already mentioned, we didn't have the time to go through a formal grade process for everything. And we had to acknowledge right up front that many decisions we were being asked to make or guidance that we were being asked to help these interregional groups decide on was based on very low or low quality evidence, that kind of certainty of benefits, questions about harms were not as fully developed as we would like to see. And that's something that Urado mentioned even in her opening comments as we got started. So throughout the pandemic, we really have tried to keep Kaiser Permanente's evidence network connected. We have this central evidence services unit at our National Care Management Institute, but also there's a Southern California evidence-based medicine services unit. Our Washington region has a really strong evidence group. You know, we would connect intermittently with the Kaiser Permanente evidence-based practice center in the Northwest to kind of compare notes on what they were seeing. And we also have a really strong relationship with our clinical pharmacy department and its drug intelligence services. So we really have tried to keep an interregional evidence repository going across the whole pandemic. The other thing that I'll mention is that other than the EPC that we have in the Northwest, none of our evidence services shops really have the bandwidth or the manpower to do big systematic evidence reviews. So we are often looking to the international community, to the US EPCs and to the Cochrane centers to try to help summarize evidence that we then bring to our clinical leaders to help think about the guidance that we want to develop. So across the pandemic, we've developed guidance on many questions. You know, early on, we were looking at questions of testing and diagnosis. There have certainly been questions about various treatment options throughout the pandemic. And there's also been things like looking at evidence for personal protective equipment and reuse of N95s, and what's the data on on being able to reprocess those things to be used when we were concerned about supply issues for PPE for our clinicians and care teams in our hospitals and care delivery settings. Another really important thing that we tried to support both at the national level and in some of our specific regions was the need to do some physician and provider education to bring them up to speed to move into different care delivery areas than they had been, to kind of increase the ability for them to take care of higher acute patients than they were used to. So in some of our regions, especially the big ones in California, there was an effort to create kind of a pyramid structure of using a critical care and pulmonary medicine person as sort of the team lead, and to bring hospitalists in to become kind of mini ICU experts, if you will, managing sets of patients, and to move ER physicians into hospital settings and urgent care people, primary care people up into urgent care and emergency departments. So there was a great need.
Craig, we can't hear you well. Jose Luis, could you hear Craig?
No, Craig, we can't hear you.
I think he can't hear us.
Craig, do you hear us?
That's why I typed in case he cannot hear us.
No, we can hear you, Craig. Can you hear us, Craig?
Maybe you should move to the next speaker and then come back.
Yes, let's move to Dr. Vazquez, perhaps.
Yes.
Actually, it seems like Craig is connecting. 1 second. I see the 3 dots next to his name.
Okay, we are going to move to the next speaker.
Okay, we'll move to Dr. Vazquez. Yeah.
Our next speaker is my good friend, Dr. Juan Carlos Vazquez from the National Institute for Respiratory Diseases in Mexico, where he was at the epicenter of the pandemic in our country, the most important hospital for respiratory diseases in our country. He's also a well-known opinion leader and in our country and the region for management of respiratory diseases and co-author of several national and international clinical guidelines. Thank you very much, Juan Carlos, for accepting our invitation.
Thank you, Jose Luis. Thank you very much to Jean. This is a great pleasure and honor to be here. And as you can see, Jose Luis is a very good friend of mine. Thank you for the nice presentation. I apologize, I don't prepare a presentation. So I rather to prepare a document because I have to fit to my fluency of my English and also to the time, which is very limited. So I prepare a short document. Of course, my disclosure is no financial conflicts of interest, and I entitled COVID-19 in Mexico Challenge for Developing Clinical Practice Guidelines. In the months of March and April 2009, the first cases of the new pandemic flu H1N1 were diagnosed in Mexico City at the National Institute of Respiratory Diseases, better known as the INER. On February 27, 2020, the first case of COVID-19 by the new coronavirus SARS-CoV-2 was diagnosed also at the INER. The INER is one of the 13 national health institutes of Mexico, which belong to the Federal Secretary of Health, and for more than 8 decades, INER has been the main responsible for care, specialized training, and scientific research on respiratory medicine. Mexico is a country of just over 126 million inhabitants. Almost 80% of Mexican populations live in the cities. Only in the metropolitan area of Mexico City live about 22 million people. 1 in 5 Mexicans lives here. As mankind has known it since the time of the plague, and without no doubt, this overcrowding cities is a conducive environment to epidemics. Like many Latin American countries, Mexico exhibits a demographic transition. Chronic degenerative diseases, violence, and infections coexist as the main causes of death. In Mexico, 32% of adult population suffers from obesity, 25% have hypertension, and 11% have diabetes. In addition, Almost 10 million Mexicans have asthma or COPD. More alarmingly, about 1/2 of people with chronic degenerative diseases do not undergo regular medical visits and proper disease control. Alejandra Contreras et al. From the National Institute of Public Health of Mexico analyzed and published recently the association between the level of municipality and mortality from COVID-19 in Mexico for the first 143,000 confirmed cases and for almost 19,000 deaths. Main variables associated with a higher mortality were prevalence of obesity and diabetes, the local mortality rates for diabetes, the density of the population, and the proportion of economically active population and the indigenous population. This week, Mexico will reach 2.2 million confirmed cases of COVID-19 and 200,000 deaths. It is the third country with most deaths in absolute numbers, only surpassed by US and Brazil. In addition, it is the country with more fatalities in health professionals. An official report from the Ministry of Health of Mexico last March 15 reported more than 230,000 health workers infected by SARS-CoV-2 and more than 3,500 accumulated deaths. Infrastructure and human resources for health are another important variable to understand the impact of the pandemic in Mexico. Before the year 2020, among OECD countries, Mexico ranked 6th lowest in health spending per capita, only 1/4 of the average. It was the 4th lowest country in terms of the number of hospital beds, also 1/4 of the average, and 7th lowest in the number of nurses. The number of doctors and specialists is also very low, even compared with the rest of Latin countries. In the entire country, there are less than 1,000 pulmonologists and less than 2,000 specialists for critical care. Almost 1/2 of these specialists are in Mexico City, so there is a great inequality at the national territory. Just before the pandemic, and for the first time in decades, the Mexican government recognized that there was a national deficit of more than 200,000 doctors, many specialists, and more than 300,000 nurses. Facing the monster of COVID-19 in Mexican scenario is a major challenge for authorities, health professionals, the scientific community, and the entire society. It is a country with already many sick human beings and an economically very limited health system, which has made the greatest effort to avoid its collapse and countless additional deaths. Many hospitals had to be partially or fully converted to COVID-19 care in Mexico. Among these hospitals is the INER, the hospital where I work. Founded in 1936 to deal with another pandemic, tuberculosis. So we haven't changed much in the history. The INER converted the total of its hospital beds to critical care beds. Actually was the only one hospital with this condition. This winter reached nearly 200 hospitalized patients with severe disease and nearly 150 patients under mechanical ventilation. Since the pandemic flu 2009, its health professionals and scientists have become as well the largest group of specialists responsible for medical research and education on the subject. Worldwide, and like never before, scientific and health community has seen a generation of enormous amount of scientific data regarding one disease. Today, in PubMed appears more than 115,000 results with the term COVID-19 and more than 4,400 results with the merged COVID-19 and clinical trials. Translating all of this information into clinical practice guidelines that meet quality standards and providing a strong recommendation will still take some time. Instead, the main national and international organizations have mostly generated official. However, for countries like Mexico, with an enormous social and economic disparity and excessive pressure of care, the greatest challenge is to implement these guidelines and educate the medical community and health professionals from all levels of care. Despite the great challenge, we face from COVID-19 in Mexico, there are also great opportunities. Respiratory medicine and institutions such as the INER have not received as much attention and investment since its foundation in the days of tuberculosis. After more than 10 years of uninterrupted requests, in this March, we registered more than the double in the number of new residence fellows for our 6 respiratory specialties. Previous to this, we had a huge deficit of residents. Technology and social networks yield another great opportunity. Canal INER, our official YouTube channel, has become the main media for communication and health education in Mexico in the past year. Like any YouTuber anywhere in the world, and with not much technological investment, live broadcasts, conferences, webinars with international experts from their hometowns, and with health educational videos have overpassed more than 1 million reproductions, reaching any part of the national territory and beyond borders. To consider that COVID-19 pandemic is an isolated event in the recent history of mankind would be a great mistake. Rather than this, it is the beginning of a continuous and long-term effect resulting from a global population explosion and an alarming climate change, as well as the invasion and destruction of natural ecosystems. Poor and emerging countries face the greatest challenge and also represent the greatest challenge for the entire world in controlling emerging and reemerging diseases. Only science, conscience, social and political responsibility, and humanism could make a common front to overcome this challenge. And I think with this, I could fit to my time. Thank you very much.
Thank you very much, Juan Carlos. I think Craig is ready to resume his lecture.
Great, thanks so much, Jose. Sorry about the technical difficulties, everyone. Let me try to just share my screen again here.
Craig, we can give you your 5 minutes back.
Great, thanks, Gerardo. So I think this was about where I was when my audio cut. I wanted to just mention that throughout the pandemic, we've set up various programs to, oh, you know what, Gerardo, I'm sorry, there we go, okay. We've set up various programs to address topics as they've come up. And so this is just an example since last fall where we had set up a new program around the COVID vaccines and had set up various work streams to look at evidence up front, to then think about vaccine supply and delivery, care delivery operations in each of our regions, kind of thinking about our physicians and employees and how the information needs that they would have, communications both internally within Kaiser Permanente and then to our members and then to the community, thinking about quality issues, some data and analytics. I think you know, most people, everybody in the US is aware of the different allocation and prioritization frameworks that have come out around the COVID vaccine and trying to kind of track our performance and how we're doing getting vaccines to people and getting them fully vaccinated has been something that's been important. And then thinking about our members and our patient experience in getting the vaccine. So this type of program we've stood up intermittently as needed throughout the pandemic, and we've stood up various kind of tiger teams, as we call them, to address urgent needs, and all of them start with asking a question of what's the evidence for this. So just quickly, some of the work that we've done at the national level around evidence surveillance, I wanted to mention. You know, we kind of realized that new studies were coming out frequently. They're offering only weak evidence. Our national CMI evidence services group had critiqued several studies and compared results with the body of evidence and current guidelines. And we started implementing a regular surveillance to monitor for significant changes in the evidence and guidelines, and brought this to our infectious diseases chiefs weekly meeting. So I think I had said this before my audio cut, but at KP, we're really looking at other groups that have done some evidence summary and trying to then help our clinical leaders kind of understand the quality of the evidence that we have to work with, the certainty we have of benefits versus harms, and to help them think about the decisions they want to make. So we haven't followed the grade process exclusively throughout this, but we've tried to keep that in mind, that that's our general approach, is to really try to help clinical leaders make decisions based on the best available evidence that we have. So this is just kind of a quick example of some of the format we put this in for them. This is one around medications, looking at a drug like convalescent plasma, mentioning when it's been updated, looking at kind of the regulatory status of that in the US, the evidence summary that we have to look at, and then what external entities like the Infectious Diseases Society of America is saying, or the National Institutes of Health. So these are the types of products that we brought to those interregional groups. And then we also run a web-based internal national clinical library where we had created a COVID web page, and this is where we would post guidance. So this is just a quick example of a guidance statement that we posted around medications. And I know it's a little bit small on the screen, but we will distribute these slides afterwards. That has just kind of a statement up front about this guidance being created based on the expert consensus of our KP Interregional COVID-19 Infectious Diseases Expert Group. The recommendations will be reviewed and modified routinely as new evidence emerges, and always kind of putting a date stamp on that so that folks are aware of the last time that these documents have been updated. And then we organized all of this guidance in a kind of a COVID landing page, a COVID splash page, if you will, where we had it organized around, links to regional sites where there was more specific information based on the state you were working in, the region you were working in, putting our latest national guidance at the top, and then developing some chapters, if you will, on clinical management, like vaccination information, prevention information, testing, treatment, special populations, then healthcare worker protection and PPE. So, across the year, we've created over 150 guidance documents that we've maintained, dropped when they weren't relevant anymore, or updated. And we've had kind of well over 300,000 hits on this page to look and see, what the latest evidence that we've put together is. So throughout the pandemic, we've been able, in our clinical knowledge services, our evidence services across the program, to really shift up the things we were doing before and to jump in and support our organization in its response to COVID-19, and have been really seen as a great value and benefit for Kaiser Permanente in its care delivery and the health outcomes that we've seen with our patients throughout the pandemic. So I'll stop there. Thanks.
Thank you very much, Craig. Our next speaker is Dr. Samir Gupta from the Canadian Respiratory Guidelines Committee. Dr. Gupta wears many hats, and today is not only going to share with his clinical experience with COVID, but also his role as a medical advisor on Canadian TV for the Canadian Broadcasting Corporation. Thank you very much.
Thank you, Jose Luis, and thank you to the organizing committee for inviting me. I'm going to talk about the question in front of us today, mostly from the perspective of the Canadian Thoracic Society, but I'll also, as mentioned, try to bring a few different angles to this question. In terms of disclosures, I don't have financial disclosures, but I do chair the Canadian Respiratory Guidelines Committee. That's a committee that produces guidelines at our society. I also contribute directly to guidance, some of the guidance that we've produced in COVID, and one of the areas of my research is guideline science. So ours is the National Interprofessional Specialty Society for Respirology, or as my colleagues down south would call it, pulmonology. It was formed in 1958. We have over 1,000 members that include specialists, primary care docs, researchers, and other interprofessional healthcare professionals across disciplines. The mission of our organization is to promote lung health by enhancing the ability of those healthcare professionals through leadership, collaboration, encouraging, supporting research, and learning and advocacy. But fundamentally, what a lot of that boils down to is production of guidance. And that's probably where a lot of our energy and resources go, and what for many providers around the country, what we're recognizable for, what we're known for. And I'm going to talk a little bit about the dilemma, the pull between clinical demands and the problem of capacity. At the best of times, we have this tension between these two things, in that our model, which I think is the case for many societies like ours, is that our constituents, clinicians and scientists, they provide leadership and expertise and they provide time, but they do that as volunteers. And they do that because our organizational objectives align with their own objectives. But when you have a sudden and unexpected increase in clinical demands that are brought upon by something like a pandemic, and particularly when it's a respiratory disease, those very same constituents, respirologists, intensivists, respiratory therapists, the people that make up our guideline groups are also among the first to be called into clinical duty. And so that created even more than the usual tension that we face. And we knew that there was a rapid and growing need for guidance, and that our society should take a lead in providing guidance in what is essentially a respiratory condition. But we also knew that there wasn't enough time for us to carry through with our conventional guideline processes. And at the same time, we were facing the issue of shrinking human resources and capacity. The same people who sit on those guidelines committees are the people who are being called into clinical duty. And so just to give you a sense, like many organizations, we are very focused on methodology at our organization, and what it takes from beginning to end to get to a guideline at the Canadian Thoracic Society is a process where we set priorities, we establish a guideline panel, we develop a process for public and patient involvement, we work out conflicts of interest, we formulate our questions, we look at other guidelines and think about formal adaptation frameworks, we do our lit search, we appraise the literature, we use the grade workbook extensively for our evidence tables, we worry about intrinsic implementability and focus on language and format of our guidelines, we reach consensus by voting, we write our sections, and finally there's an external and an internal review process with experts usually around the world. And like for many organizations, that process, to do it right, takes about 2 years. And that is the best. That is what we are confident will bring us closest to the truth and to an unbiased truth. But we recognize that the best shouldn't be the enemy of the good. And we have another mechanism for guidance called position statements. Position paper, as we define it in our society, is usually an opinion piece. It's something that's informed by best evidence, but not necessarily supported by a systematic evidence search. And we limit that. We try very desperately to limit the use of this kind of guidance document to very specific circumstances. The first is when you want to summarize key issues relating to a specific clinical question. In this context, that question might be, can and how should respiratory disease patients wear masks? Who should be prioritized for vaccination among respiratory disease patients? And particularly in light of new evidence. And there's nothing like a novel coronavirus to drive the point home that everything is new evidence today with respect to this pandemic. And the other criterion is urgency must be required. There must be a need for urgency to justify doing something less than a formal guideline process. And although we rarely would actually go the route of position statements, there's been a huge pivot, the COVID pivot, we call it, at our organization, whereby these are all of the COVID-related guidance statements, and they're all position statements that we've produced in the last year. We very early organized a COVID-19 task force that led decision-making around what kind of guidance we would produce. We haven't been quite as prolific as what Craig told us at KP, but we have produced 15 position statements, and 3 of those have already been updated at our organization. Everything from school return for kids with asthma to how to manage asthma in a pandemic, how to deal with shortages of medications like salbutamol, an issue that's around the world right now, a clinical triage threshold. So how do you triage patients in light of limited ICU resources? How do you treat COPD in the pandemic? Who gets to wear face masks and how with respiratory disease? ILD, how do you manage ILD with limited resources? How do we do pulmonary function testing and pulmonary rehab? How do we manage sleep disordered breathing? And how do we prioritize vaccination? And we've done all this guidance in a very short time. And what's been an interesting and unexpected benefit for us is that our sister society in the US, which is the CHEST, or American College of Chest Physicians, has taken an interest, taken note of what we've been doing, And it's led to our asthma, COPD, and sleep disordered breathing, and even our clinical triage thresholds documents appearing in their journal for their constituents in a summarized form. And that's been really interesting for us because they are a much larger organization with a larger reach. And that means more visibility for our organization, people becoming aware of our guidance. It's also a nice academic reward that we can offer our guideline writers. Their journal is a much higher impact journal. So to bring that academic piece in, that carrot for folks volunteering to do this, it's been a very nice bonus for us. And in terms of reach, we've seen, similarly to what you've heard from other speakers, a dramatic increase in traffic to our website. So in light pink are the web views from the previous March to March, 2019 to 20, and from 2020 to 2021, we've pretty much doubled our web traffic. In terms of guidance downloads, 63% increase in the number of guidance documents actually being downloaded from our website. So very gratifying for our guideline writers and for us organizationally to know that we're getting that uptake. We're also getting that uptake from different parts of the world that we were not previously reaching. As you can see, mostly from Canada, but also from the US, from India, the UK, France, tripling of access to our content from China, which is obviously the epicenter of the pandemic, but a lot more international reach for our content. We've also, for the first time in the history of our organization, focused on public-facing campaigns. So we've had a formal social media campaign, for example, for patients on how to wear masks. We've also targeted decision makers with our social media campaigns, for example, here advocating for respiratory patients to be prioritized for vaccination, new areas for our organization. And we've had new opportunities to lead. An example is very early in the pandemic, our Health Canada, our federal organization that deals with drug shortages, invited us to be around the table discussing how to manage drug shortages for inhaled medications. And these are doors we've knocked on for years and often haven't gotten into. And I think the visibility afforded by all of the guidance documents produced by our organization in the context of the pandemic has enabled us to then be around these tables and be on the radar of these guidance and these sort of decision-making organizations. A month later, we convened a roundtable, which continues to meet bi-weekly now, of 20 respiratory partners, the goal being to prevent duplication, but also to ensure that synergies between our organizations are being fully leveraged in terms of when we produce guidance. In July, our statement on pulmonary function testing was taken up by the government of Ontario, our largest province. So we're starting to get that interest from decision makers. Similarly, our guidance on clinical triage thresholds for severe respiratory disease patients has been taken up by 2 different provinces, governments, which is unusual for our organization to get that level of uptake. That all has culminated in a pre-budget submission by our organization to influence the national budget that's coming out, again, with the role of advocating for respiratory patients to be in that budget, whether COVID or not, in terms of both streams of funding. And that also represents a new level of influence for our organization, which we believe is driven largely by our success in providing guidance in the context of the pandemic. A little bit of a tangent about COVID-19 science and the media. And I bring this up because I work in health media and I've done that for 7 years. And I have seen a large number of parallels between some of the dilemmas we face as a guidance producing organizations and some of the dilemmas I face as a clinician and a scientist speaking to the media and speaking to the public. I work as a medical correspondent currently for a national broadcaster, and I counted. I've done 99 television segments in the last year. Tonight will be my 100th. And I can tell you that I've never seen this level of interest, this level of demand from the public and from media.
Samir, we have 2 more minutes. Thank you.
Okay, for expertise, whether it's scientific or medical expertise, our videos, we produce videos on masks and gloves. We've had more than 1.5 million views per video. We're getting just an immense amount of interest from the public on scientific content. And with this appetite, to me, it represents an opportunity, which is probably once in a generation, to drive faith in science in the public, but also to drive scientific literacy. The dilemma, of course, is that the public and the media wants a compelling narrative. Compelling narrative is something you can wrap up in a bow, and it's a question that you can answer. What we have with evolving evidence is more questions than answers. That's what science is. And sometimes that leads to mistakes, and sometimes that leads to a trust problem. Famously, Dr. Fauci changed his position on masks in light of emerging evidence, which is exactly what should happen. But some in politics and some in the public will get focused on that. And that becomes a point of weakness, and it becomes a potential point where trust gets broken between the medical and scientific establishment and the public. And we are making recommendations on the basis of phase 2 data, small data sets, modeling studies, things that we would never be using, things that wouldn't score well on a grade system, but things that often are all we have to make recommendations, and sources that I'm going to, when I'm speaking to the media, that I would never normally go to before the pandemic in my media work. We're talking about preprints. I would never have imagined talking about scientific literature that's in a preprint server, let alone small studies that are published in peer-reviewed literature. And I should say we're also now dealing more and more with science by news release. And all of that, to conclude, I think just underlines an increasing need for scientists who know their science but are also effective science communicators. Thank you.
Thank you very much, Samir. Our last presenter is Dr. Adrienne Stevens from Cochrane, Canada, and McMaster University, who is going to speak with us about and the demo Cochrane COVID-19 Living Recommendations Map and Gateway and Contextualization. Thank you very much.
Thank you, Jose Luis, and thank you to the organizers for inviting me to speak. And I think even from panelists here and those in the first panel, just even speaking to some of the pressures and tensions about when wanting to make decisions and having to then creatively think about how to introduce evidence in that, given the context with the other demands and pressures. And so I appreciate what that means, and even for some having to change how they go about doing this because of the pandemic. What I want to talk to you today about is a tool that we've developed that our desire for which is to help meet that need, to help expedite decision making. And so what I'm going to do is I'm going to spend the majority of my presentation basically walking you through this tool, having it as a live demonstration. I have also provided the organizers a set of slides that gives you some more information on how we developed this resource, and some screen captures of what I'm going to show you live here. If I have a few minutes at the end, I may flip back to the slides, but if not, you have access to them. And maybe just to share in terms of any disclosures, I don't have any direct financial conflicts of interest, but I've certainly shared my affiliations with Cochrane Canada, the GRADE Working Group, and the McMaster GRADE Center. I am also a co-author on one of the guidelines that is actually featured in the recommendations map as well. So what I'm going to do is I'm just going to walk you through this tool. And so this is our e-COVID recommendations map and gateway to contextualization at covid19.recmap.org. This is the landing page, just to show you on the top right when you access this hamburger menu. If you want to know a little bit more about the recommendations map, who we are in terms of, and we have a very large international team, just to say I'm one of this large team who's putting effort into this. So a shout out to our colleagues in doing this. But if there's additional information related to a glossary, certainly if you do use the portal and have any feedback, please do provide that to us. And so as you see at this front landing page, your enter in is you could do sort of a text word search for a particular topic that you may be interested in. We've also organized it in terms of a map and a list. Now, I've found when I've given these presentations, sometimes the system is a little bit slow. So I've sort of primed the presentation. So if we were to access the list, it is very much this. It's a list of the recommendations that exist in the map. We have also organized it so that you can filter according to, maybe some areas to help whittle down to what your interest is. Maybe you're interested in the particular source, maybe to patients with coexisting conditions. And then in terms of recommendation types, as we've encountered the literature, we've recognized that there are some recommendations that are made using a formal process, some with not as much of a formal process that would be this additional guidance, and ones for whom groups have issued that maybe they didn't feel the need to necessarily dig into the evidence because it was more of sort of a good practice statement, and they didn't need to do that. So we recognize them and have coded the recommendations accordingly. So this is the list view, and even if I just hover over the recommendations map, you see that there's another organized structure. So that is the map. So this grid shows the recommendations in broad categories according to what the recommendations represent. And just to add that the unit of organization of the map is in relation to recommendations, knowing that a given guideline may have more than one recommendation. So organized according to broad topics along the top, and then by patient populations down to the left. We do as well have a filtering system here with the map. That again, it's the same scheme as with the list. We also have a heat map, so you can get a sense of volume of recommendations for a particular area. Now, as you can see under treatment and rehabilitation, just for those who have COVID-19 confirmed, there are quite a few recommendations. So we've added another layer of organization so that for treatment recommendation, we further categorized it to give you a sense. So if you're interested in something, let's say related to ivermectin, you could scroll over and see that we have some recommendations related to ivermectin in the map. And then if you select a certain recommendation, for example, so there are two here, what you see is the recommendation itself, its strength. So whether it's for or against a particular action, and then strongly or conditionally so, and what the source of the recommendation is. You can highlight the recommendation if you wish to go through the map and pre-select a number. So what I've done is you can also dig into additional information. So let's say there was interest in vaccination. So I just did a simple truncated keyword search. So it does accept truncation. So let's say I was interested in guidance that was issued by the CDC. So here I could open this up and we see recommendations here related to Pfizer and Moderna. If I select a given recommendation, or it could be a good practice statement or additional guidance, then that opens up an additional page. And here we see the recommendation. Adjacent to it, its certainty of evidence. Again, the direction, the strength of the recommendation. We appraise all guidelines using Agree to. We use a subset of domains, focusing on those related more to credibility of the aspect of the tool. What's nice too about this particular recommendation from the CDC is there's quite a bit of information that they provide. And so we extract what there is available to then populate on the map. And you can use this menu to the right-hand side to be able to access the additional information. So, and I'm just going to scroll down initially here. So this next sort of box of information gives you more sort of a PICO style of information that it's presented. You can link out if available. You can link out to the evidence table that underpins that recommendation. As well, we've provided links out to both the Epistemonicus Love platform, as well as the living evidence map that was produced by the Norwegian Institute of Public Health. And this gives you access, if you wish, to additional information, especially if you're thinking about contextualizing the recommendation to your local decision-making circumstance. Additional information, I'm just going to scroll down a bit more, looks at the justification, subgroup considerations, implementation. If you're interested in a snapshot of what their summary of judgments, and this is structured according to the GRADE evidence decision framework, then this is provided. If you wish to see the data that underpin that particular recommendation, here we provide your interactive summary of findings table where you can access the information. I'm just going to move down towards the bottom of the page. You see the source of the recommendation. And then at the end, there is this. So this is your opportunity if you wish to engage with this information. So this is the adultment module. For those perhaps not familiar with adultment, that's thinking about existing guidance and do you adapt it as is, or do you adopt it, sorry, as is, do you adapt it to your local circumstance, or given what the content poses, maybe you're thinking about creating a new recommendation. So this allows you to access this recommendation, and you can go through yourself and determine whether or not there's additional information to be able to contextualize. Sorry, I think there may be someone else speaking on the line, and perhaps maybe just a note for folks.
Me too, so much.
Thank you. So yes, I think this is, we would really desire and wish for engagement with this. And I think this development module gives folks the ability to do that. And if you would develop a recommendation, that it too can appear on the map and other users can see how you've used that recommendation for your decision making. And as well, it does indicate that it's an developed recommendation. Okay, I think I'm pretty close to my time, Jose Luis. Maybe what I will say is, you can access the slides. It does show you the development module and how that information is juxtaposed and how you can enter that in the map. So thank you very much.
Thank you very much, Adrienne. Thank you to all our panelists for presenting such retrieving information to which we can all relate and from which we surely all wrote down some lessons to take home. Now let us turn to some audience questions. Please, Maria Michaels, do you have some questions for our panelists?
I do, and I'll also mention first that there's been a bit of an exchange on some questions in the chat, so feel free to check that out if you haven't already. I'll start with a question for Juan Carlos. I understand that during the pandemic surge, your group organized a weekly conference call involving about 2,000 participants. Could you say more about that?
Your microphone.
I'm here. Sure. We decided to organize several types of conferences. Once a week, a conference for COVID-19, especially last year. And in the first one, during the February, was a huge amount of requests to see the conference. We reached a record number, more than 5,000 connections in the YouTube channel, and we have some conferences already in the channel and some courses and professional videos, for example, for the use of personal protection equipment. And it has been a huge success for educational purposes. And Mexico is a huge country, and as I said in the lecture, there is a huge difference between the distribution of doctors, educational universities, and everything in the country. And some states in Mexico have a very low numbers of respirologists and scientists. So this experience for social media and social networks is one of the best experiences we had during the pandemic. So I think for poor countries or emerging countries is a great opportunity to reach all the territory and even other countries. So we are now organizing COVID-19 conferences and also for other kind of conferences, because our major concern now is the length of the pandemic in Mexico and in the world, of course, and the availability of information and teaching and educational for non-COVID purposes also.
Thank you. Question for Craig. How did you determine which evidence sources to monitor regularly during the pandemic? So for example, were there certain criteria? Were these sources you monitor anyway? How did you determine that?
Thanks for that question. We certainly used our connections in the evidence-based guideline space. So Guidelines International Network, GRADE Working Group, we looked at WHO, evidence-based practice centers. And so, so those are the types of organizations, entities that we look to in general, and we tried to use them kind of as our first go-to source. Like I did mention, though, we also started to look at some other guideline authoring entities, especially in the U.S., the Infectious Diseases Society of America and the NIH. We paid particular attention to, given that they also do, try to follow the GRADE method, at least IDSA does. So that's kind of how we did it. Sort of trusted people that we knew did high quality systematic evidence review, and then some of the trusted groups that would try to work on creating guidance from that evidence.
Thank you. Question for Samir. You mentioned that we've used sources during this pandemic that would have never previously been used, and in general doesn't conform to grade. Do you think this will remain the approach going forward, or do you think we'll go back to how it was before, and why do you think that?
I think for people in the science community and people in the guidelines, guidance development community, it probably won't stay that way because there's a lot of discomfort around using these sources. It's not like the fact that we've been forced to use them has led to a comfort level or happiness necessarily using those sources, and we've been burned by those sources as well. But I do wonder for the media, there's a lot of science illiteracy in the media as well. And there are health journalists that are very sophisticated and understand about levels of evidence, and there are many who don't. And I think there may be some lasting effects in the media, and we may be seeing more and more post-pandemic use of questionable evidence sources for stories in the media. And again, I think it's our role to continue to be part of what gets delivered to the public by engaging with media. I think for me, it's a part of my job now, and I encourage my colleagues to make that a part of their job as well, because that's how we're going to have impact, is to make sure that scientific principles are espoused in the information that's going out to the public, which often is much more impactful than the information that's going out in the peer-reviewed journals in terms of moving the needle on public behavior and even decision makers, which direction they're going in.
Thanks. Could you actually expand a little bit about your experience, since you've said that tonight will be your 100th time kind of presenting through the media on this topic? How did you sort of convey the absence of typical type of information without allowing the audiences to think that, say, frontline physicians don't really know how to manage people with COVID?
Yeah, I think it's always about couching your statement in a brief proviso about the type of evidence that's informing your statement. And so often, we're talking about public health impact of now a third wave, and many of the data are based on modeling studies. And so I'll always start my statement by saying, look, these are based on modeling studies and there are assumptions in there. But then I'll often say the models that we're looking at have been very accurate for wave 1 and wave 2. So it's not, it's not as good as what, the typical stuff that we would use, but we're in a position where we're using those kinds of data. Sometimes it'll be, we just have got this press release from AstraZeneca about the effectiveness of their vaccine in the US trial. And already there's a proviso that's coming out from the FDA. But I'm going to be talking about that tonight, and I'm going to be saying all we have is a press release. We don't even have a preprint server publication, let alone a peer-reviewed publication. So what I'm going to be saying is, well, what AstraZeneca is saying is that it's 79% effective in the US population, but I'd like to see the trial. So you have to talk about what's out there, because if you don't talk about it, someone else will. That vacuum will be filled. If I say, no, you know what, I can't talk about it till I see the paper, believe me, somebody who is maybe not qualified, maybe a pseudoscience view or a fake news view will get out there. It will fill the vacuum. So you've got to talk about it, but you've got to talk about it in a way that you're true to the evidence that's there, reflecting the level of confidence you have in that evidence, but still you've got to talk about it.
Thank you. In a related question, actually, I'll ask Adrienne to start answering this. What's being done in communications by trusted experts to emphasize the evolving nature of evidence and uncertainty, and to encourage debate rather than dismissal of alternative options as conspiracy theories? So an example of suppression of evidence such as ivermectin, I think it is, and question that why this has not been given attention by experts and the media. So actually, I think part of it might be a follow-on to your response just now, Samir, and then I think some of it could be a response from Adrienne on the way that you present information on your platform.
Yeah, that's a great point. And in fact, one piece I didn't get to that's in the presentation is that, our next step is wanting to move to plain language versions. And I think that's a piece for thinking about the stakeholder, for which we would include media in that, I think would be key pieces. I think for us, there's, it would be great to have those points of outreach with media. And I think, which really has largely happened yet. But I think would be a great opportunity to be able to have that. And obviously using the rec map as a source to be able to sort of step forward based on.
Thank you. Anything additional to add, Samir, before we go to the next question?
Yeah, no, I'll just say that it really has to be a conversation. It's really important that scientific voices in the media do not dismiss what might be perceived as unscientific notions or fringe notions, because there are just a surprising number of people out there who espouse those theories. And it's because they fall prey to very sophisticated information that's on the internet. It becomes very hard to distinguish what is scientifically based and what isn't. And so that's a big part of our job. And it's a part of the job is to engage and to have conversations. And there's always a risk that people will perceive it as somebody from the science worldview talking down to their worldview. That's very detrimental. And if you start from that position, you'll never get those people on your side. You'll never get those people to see it as you see it. So I think that initial posturing is very important in engaging.
Thank you. Question for Dr. Vazquez. How are the new challenges facing our colleagues in Mexico as the pandemic evolves? And how can this community be of service to you?
Good question. The pandemic has evolved so quickly. So sometimes we think we are not evolving so as quickly as the pandemic. So especially because the social health, the health system is under a lot of pressure for care more than for scientific and educational purposes. So, and I think there should be a better plan to keep some human resources and scientists and educational resources for proper planning and giving education and proper training in the whole country. So if we are overpassed by the pressure of care, because as I said, the health system is very limited in the size and economically, we'll never go through this pressure, So, and I think we need to overpass this crisis and to get better prepared for the rest of the pandemic and the next pandemics. So if we don't overpass, we already survived 2 pandemics, especially at the INER. So it's just crazy to organize education and research when all the pressure is over care and so the bureaucracy is crazy. So, and I think that we need a break, hopefully in the next months, and then to get some forum like this one to analyze and to better plan, because it's just such as firefighter work, just to fire the fire, this crazy thing. And we need more time and more resources, human resources especially. The biggest problem in Mexico is the specialized human resources. The number of specialists is extremely low, and it's a very bad policy in Mexico, and it's changing, fortunately. But it's going to take many years to overpass this problem.
Thank you. There was one more question in the chat, so just wanted to point out it was to Adrienne, and she answered in the chat. And I will send it back to Jose Luis if you have anything remaining to say.
Nope. Thank you very much to all our panelists.
Yes, thank you so much. I think we are going to take a 30-second break again. Thank you so much thank you to our audience members for accommodating our timeline. Our speakers are so riveting that we are having a really hard time asking them to stop short of completing their talks. So we are passing on our breaks in the interest of hearing more from our speakers. So if you take a 30-second break, we will come back to our third and final panel. And thank you again to all our speakers on panel 2. If I could also ask the panel 3 speakers to open up their videos so that I could spotlight them. Mary, let's get started.
Wonderful. Hi, everyone. Here we are, the last panel of the day. My name is Mary Nix, and I, as immediate past chair of GIN North America, I'm pleased to moderate this panel. During this final panel of our day together, our goal is to continue to stimulate your thinking about how we can do better next time we're faced with a situation like COVID-19, where clinicians and those they serve need guidance to hustle, to support health and wellness, because time is super short, information coming from many sources is conflicting, and questions of trust really grow. This panel of speakers was chosen to relay efforts underway and maybe even forgotten, that is perhaps not forthrightly applied in recent efforts, to help us do better the next time. I have asked our panelists to stoke your curiosities, accelerate your thoughts toward meaningful discussions, and assist in advancing our collective improvements. To that end, in day 2 of our event, we ask that you bring what you've learned from this and our other panels today, coupled with your experiences, to help all of us improve our actions, our outputs, and our outcomes. All the speakers' bios are in the program material. It's not my intent to state who they are or where they're coming from. I'll state who they are or anything more about them, but I do want to just tee up what they're going to be talking about. Dr. Yvonne Flores is going to talk to us about COVID End and the COVID-19 Guidelines group. Many of you may know Dr. Flores, by the way, in the GIN North America community, because he's spoken on webinars about the AGREE instrument. So welcome back, Dr. Flores. Juan Patterson is going to speak to us about his experiences as a credible messenger and a bridge to communities, to government organizations, and to non-government organizations, including healthcare organizations. Jerry Osheroff, Dr. Jerry Osheroff, is going to talk to us about care transformation and this COVID Guidance to Action Collaborative, which I think you'll want to especially listen hard to. Not that you don't want to listen hard to all the speakers, but I think Jerry has got something that we're going to talk a little bit more about. We'll probably want to talk more about tomorrow, and I saw in the chat in the last panel where this came up. And then lastly, pulling up the end and bringing us back to some realities. We have Cindy Brock from the AHRQ and the Department of Health and Human Services, who is a leader, an expert in the domain of health literacy. And we've heard that referenced in the last panel regarding science communication and plain language. So welcome panel 3. Dr. Flores, the mic is all yours.
Thank you so much, Mary. We'll start sharing here my slides. You should be able to see my slides now. Is that right?
Yes, we see them.
Perfect.
Perfect.
Yeah, there you go.
Perfect. So thank you very much to Mary and to Gerardo for the invitation to talk today about this initiative. And I'll start this first slide with the name of the panel. How do we prepare to the next pandemic? Please don't expect that I'm going to prepare you during these 10 minutes to be prepared for the next pandemic. Very difficult task, but I will try to share with you some learnings of what we have been doing in the COVID-19 initiative and how this could be a good start for a future preparation for the next pandemic in terms of guidelines and evidence synthesis. So starting with the disclosure of interest, I certify that I have no conflict of interest to declare. I am the current leader of the Agri Collaboration and the director of Cochrane, Colombia. And but right now I have the COVID-19 hat today for this specific presentation. So not going to specifically talk about Cochrane and Agri in this specific presentation. I am just here the messenger who is going to present a lot of work that has been that this incredible thing has been doing for the last month since the pandemic started. And this has been this is an initiative that started by the original idea of John Lavis and Jeremy Grinshaw at McMaster University and University of Ottawa, respectively. They just started this initiative to try to create a huge network of researchers, synthesizers, guideline developers, users, and policymakers with the aim of facilitating the use of evidence in the COVID-19 decisions. So they are the leaders of this initiative, and they're real brains behind this incredible opportunity that I've been working on in the last month. And there is also a lot of people in the secretariat that supports this initiative, and they are supported by also David Toby, who was the past editor-in-chief of Cochrane, and an incredible team of people supporting them like Anna Dion and Safa Al-Khatif, which I acknowledge today because without them this wouldn't have been possible. The recommending working group is one of the working groups COVID-19. There has been a lot of changes in the working group of the COVID-19 groups, but the group that I am leading, co-leading with Perola Van Beek, is there the long list of people. Some of them are here in this presentation. They're going to present, or they are just speakers, or they are just listen to this conference. So this is an incredible work of people all around the world from different continents that have been discussing the major topics about guidelines. So I'm just in representation of all this work. So what is COVID-19? It's a huge network that started last year with the pandemic. This is a time-limited network. We didn't create it like a network to continue in time. That doesn't mean we're not going to continue working, but the idea of COVID-19 was to be a time-limited process in order to help to get the response to the COVID-19 pandemic, to help two major aims: to support decision-making about COVID-19 with the best available evidence, that would be the evidence demand side, and also to support researchers in order to reduce the waste, to reduce duplication of effort, and to better coordinate the effort of people that work on this, like you, even in the evidence synthesis part on the guideline developing. And those are the two major aims of COVID-19, supporting decision maker and facilitating the use of evidence for these decisions and reducing duplication of effort. The funders of this have produced there have been several funders here. It started with the government of Ontario, the NHS chair from UK, some donors from the USA, and in the last period of time, the CIHR from Canada started with some support for the COVID and specific for Canada. COVID-19 includes partners for more than 50 world-leading evidence synthesis and health technology assessment and guideline groups around the world. It covers the full spectrum. It's not only clinical. The areas are divided in 4 domains, which are the public health measures, everything about public health, or the clinical management, health systems arrangements, and economic and social responses. And the coverage is for everyone, high income and low and middle income countries. So these are like a summary of some of the partners that are part of this initiative. I'm not going to go in there, but we, of course, the Guidelines and National Networks is part of the partner. So there are several fields of work in the COVID-19, but the most important thing that has been driving most of the advance in the last month has been the inventory of the best evidence synthesis that I'm going to show a little bit, and the Horizon Scan for emerging issues for policy, which is a process that has been composed or discussed by policymakers, citizens, and patients, the community of those supporting decision makers, the living hub of COVID-19 knowledge hub, and other support that I don't have time to go. So the inventory of best evidence that I'm going to show in the next slides, I will go more in depth. But the Horizon Scans is an initiative to have different people around the world, policymakers, citizens, patients, representatives, and decision makers and researchers who help the Secretariat to take decisions about what would be the most pressing issues to take decisions, to prioritize evidence synthesis process or guideline process or any kind of evidence-based guidance process. The community that we have has been created a list of emails in which we make discussion about the most pressing issues about this, and we have some living hub of COVID-19 knowledge hubs. But I'm going to make emphasis in the inventory of best evidence synthesis. This is an evidence synthesis hub in which we have the best evidence synthesis. The idea is to save time and to avoid duplication for those providing the frontline decision for support in the government. The best evidence synthesis has been ranked ordered within any given row in taxonomy based on the days of search, the most updated one, the quality of the evidence synthesis, and the evidence profile available, and we provide an hyperlink to the original source. I'm going to show you in the next slides. And we reward the title with some details, so it would be easy for people who want to use the information to access and to understand what is the evidence synthesis talking about. This is our COVID-19 website, and I'm going to provide you more links if you are interested. But in the COVID-19 website, you can go to the inventory of best available evidence that you can see here. And in this part, you can see a full list of specific decisions or questions about clinical management, public health, social and economical. In this case, this is a clinical question about the antivirals and what would be the available evidence synthesis that are already available, and what was the date of last search, the quality of this evidence synthesis, and if it has an evidence profile or not, which will be useful for users, implementer, guideline developers, and the link for the final access to the original source. So it has the quality always there assessed. The Horizon Scans that I showed you, here you can access to it, and you can see how the discussion going about what would be the most pressing issues around the world. And this is about the Horizon Scans. And in specific about guidelines, we have started this discussion between guideline experts, and we started with the idea of facilitating collaboration between among developers. We wanted to do a database of the guidelines of COVID-19, but we realized that the Guideline International Network was doing the same. So we said we are not going to duplicate the efforts. Guideline International Network is part of us, so we stopped there. We encourage guideline registration, which is also a process that has been encouraged by the Guideline International Network, but also by the Australian Registry, and also the Guidelines Registry, which is another one, which is available. So we encourage there. We connect guideline developers. We are collaborating with initiatives in order to have the similar objectives, like for instance, what Adrienne Stevens just presented about the e-COVID map, which in order to not duplicate efforts, we decided to collaborate with e-COVID-19 in order to facilitate that people could use this incredible map that we have. And the idea is to reduce duplication of efforts. We developed a content about guidelines methodology to support adaptation and reducing duplication, with the idea of targeting guideline developers, users, implementers, people who are interested in doing rapid guidelines, and people who are interested in adapting guidelines. This is the website in which you could find resource for researchers, support for guideline developers, and there are different resources for people who wants to do a guideline, who want to adapt, who wants to use the best guideline possible in their own context. Final 2 or 3 slides. What have we found in COVID-19, in COVID in the last month? We found a massive production of guidelines in a short period of time. But we found that most of those guidelines are of low quality. We found also that the lack of evidence for many interventions at the beginning of the pandemic led to provide recommendations about many interventions without any evidence, and some of them could be even harmful, as you should know. So the need for rapid guidance brought and magnified the duplication of efforts. This is not only about COVID-19. This has been also with duplication of effort, but with COVID, everything magnified. Evidence synthesis, guideline developers, method researchers, and dissemination and knowledge translation initiative, there have been duplication and there's still duplication. We try to reduce it, but it's still there. What have we learned? Guidelines may be developed in a faster way. We already know that. The rapid development increases the risk of low quality guidelines. We also know that. Mostly a lot of de novo development, there has been a lot of information there. We encourage people to do adaptation. There has been a lot of evidence synthesis. There is no need to repeat the whole process. And this concept of living guidelines that was boosted in the COVID pandemic, that's something that we are encouraging, but we know that it's a challenge process. It requires a lot of expenses, a lot of resources. The BMJ Magic WHO collaboration process for living guidelines and the National COVID-19 Task Force in Australia have done a great work in living guidelines. There hasn't been too much collaboration, and there is a need for more patient and citizen participation in the guideline process. And finally, what can we do to prepare for the next pandemic? So take advantage of all the things that we have improved in the last month. The improvement in method, more living guidelines, more living reviews, technology support advance like COCA or ICTS, as Jerry is going to describe later, and increased collaboration of network and all the network established, like for instance, COVID-end or COVID-19. We need to work together to reduce duplication in order to continue and research and improve the methods and the advancement for those rapid guidance and without neglecting quality. And finally, the final goal that we have, and we should be to establish a comprehensive network of organizations, patients, citizens, experts to uniform the approaches, to facilitate the collaboration, to expedite the synthesis and guidance, including adaptations, reduce duplication, and maintaining the quality and trustworthiness of evidence-based guidance. Stay in touch. Those are our channels for COVID-19, COVID-end, sorry. My email for any question. Thank you very much, Mary. Thank you very much.
Thank you. Thank you. Right on time. I didn't even have to pull the hook. Way to work it. Way to work it. You've set a high bar. Okay, great. Thanks, Yvonne. Juan, you're up. Mike is all yours.
Thank you. Good afternoon, everyone. My name is Juan Patterson. First of all, I'd like to thank Dr. Franz for presenting previously before me, because he did a great job of pretty much setting me up on ensuring that I continue to deliver on my purpose of amplifying voices and creating opportunities for those who may not have the opportunity to reach said conference rooms, classrooms, or panels such as the one that we are presenting on today. And today I'll be speaking on the conversation about how communities are receiving, digesting, and sharing information as it relates to COVID and the pandemic. And we know that previously, we have a historical level of mistrust that happened with marginalized communities due to health disparities and stuff of that nature. However, I'll take you to a story to help explain a little bit more about what brought us here to this day, and a little bit more about those solutions that help us pull us out of where we are today. Here in Baltimore, there's a stigma with community and academic partnerships because of historical medical mistrust and research experiences that led the community to feel exploited and abused. As a result of those historical experiences, it allowed stigmatism and misconceptions to happen inside the community and continue to be passed on for generations. Then 2020, March 2020 hit with COVID becoming a national pandemic, and we had to rely on a new form of how communities are receiving information where we have never been before, such as receiving a lot of our information from social media and digital media platforms. And we learned that there was a lot of disinformation and misinformation. And for those who may sometimes we get it misconstrued because it happened rather quickly. Disinformation is false information that was deliberately shared to mislead the public. So that was some things that had happened. And we had some community members that was sharing misinformation, or misinformation is false information, unbeknownstly shared without supporting accurate facts and dispelling the accuracy of the information. Now we look at, and my community, my family, to be explicitly clear, was heavily using social media such as Facebook to receive that information. And when you have a lot of communities who are historically disconnected from the academe or researchers or practitioners, they receive a lot of their information from trusted sources that looks like them and have constant communication with them. So unfortunately, Facebook helped to replace physical proximity to trusted practitioners. So now you have to work to dispel a lot of those misinformation, disinformation, and sometimes even seeing the flip-flop from the CDC saying that the masks are required, the masks were not required, and this pretty much catapult the need for credible messengers. And credible messengers are individuals who are trusted neighborhood leaders, community advocates, or partners who have a history of partnerships between academic research institutions with the community that helps to transform public issues in a relatable tones to relevant community stakeholders. And that was really important. When it came to my partnership with the University of Maryland and FDA, they had an emergency connection where they wanted to get the attitudes, beliefs, and perspectives of marginalized communities here in Baltimore to understand their attitudes towards communications of COVID-19 testing. And we realized that there was a difficulty connecting with that population, reason being because all of this disinformation and misinformation that was happening around us. But what we learned was successful was tapping inside those credible messengers, such as myself. And then once you have that level of trust, credibility, respect, and compassion for that population, they was allowed to take part in focus groups. And when they became more health literate as it relates to COVID-19 and testing and the vaccine, they then became their own ambassadors for that information to dispel a lot of the misinformation that was happening inside our communities, and where we had academic and community partnership breakdown of communication. So when we talk about the reasons why credible messengers approach is important with increasing evidence-based relevant research, data, communications is really important. Those are the things that we learned that was really helpful. And one of the things that we always try to walk away with is some best practices, the ABCs of engagement. Just because a person may resemble a community doesn't mean they're the best person qualified to connect with that community. And the ABCs of engagement that I tend to focus on and expound upon, can't do it as much here. We had a short amount of time and try to give you as much value in a little bit of time as possible. ABC is appearance, behavior, and communication. Oftentimes communication, we believe that we know the best language to reach people, but sometimes there's a motto I say that sometimes it's best to pass the mic. You may not be the best relevant person to deliver a message, but if you work in sync with others, you can deliver that message in a proper way in which you connect. Lastly, I would say through such community and academic partnerships, we was allowed to build trust and credibility with the FDA in a community who have generations of mistrust with government agencies and healthcare institutions. So if we can see that level of commitment being uplifted, included, and valued, I'm quite sure that we can begin to do things differently. And just like our keynote speaker said, I'll use some information that he said. I'll say that let's design the future of healthcare together. And I will conclude there.
Thank you so much, Juan. A really, really important perspective. Oh, we're so happy you could join us. Yeah, thank you, Juan. Let's move right along to Cindy. Juan has given us some time back. Sorry, yep, you're right, Cindy. Because I'm looking at the lineup. You're right, in my view, but you're right. Jerry's actually next. Thank you for loosening up a couple minutes. Well, I'm sure we'll use them well in this session. All right, Jerry, the mic is yours.
Thanks, Mary. Greetings, everybody. I'm really excited to be a part of this panel and part of this conference and to speak to you for a few minutes now about improving the evidence guidance ecosystem cycle in the current pandemic and beyond. So the three goals that I have for the next couple of minutes are to give you an overview of the ACTS COVID-19 collaborative efforts to improve the flow from evidence to guidance to action. As Yvonne did, share some implications of all this for the next pandemic, and end with a call to action, which is hopefully getting more of you beyond the many that are already on this call engaged in this collaborative. So this collaborative is a part of the ARC Evidence-Based Care Transformation Support, or ACTS initiative, this collaborative. ACTS started a little over 2 years ago with the goal of developing a stakeholder-driven roadmap for making information and resources from ARC and other sources more fair, computable, and useful, and to engage a very large stakeholder group in doing this work. So this roadmap would be a stakeholder-driven path from the current state to a shared future vision. So about a year into developing this roadmap, almost exactly a year ago, the pandemic hit, of course, and this group effort focused to forming and leveraging this ACTS COVID-19 evidence to guidance to action collaborative. So as I mentioned, we engaged a very large and diverse stakeholder community in developing this roadmap, and they worked for roughly a year and then shifted gears to form this COVID collaborative that I'll share more about in just a moment. And this slide highlights the wide variety of different stakeholder group types that engage in the project: care delivery organizations, standards development organizations, health IT suppliers, specialty societies, many, many others in the US and abroad as well. And the problem that we were trying to address in the roadmap that also is a key issue for the COVID collaborative is there's a cycle, a theoretic cycle, whereby we take the best evidence, we translate the evidence into actionable guidance. We actually put the guidance into action to support care and decisions, and then take the data that is generated from those actions and feed that back into evidence, more evidence, in what ideally would be a virtuous cycle. But right now it isn't anything like a virtuous cycle. And as we've heard from many of the other speakers, the pandemic is really highlighting the life and death consequences of the fact that this cycle is currently highly siloed. It's fraught with delays and gaps and inefficiencies. So not surprising to this group, we've seen a diagram like this earlier. The shared future vision that we developed initially in the first couple months of this project really called for a virtuous cycle whereby the flow from evidence to guidance to action to data is more computable, it's more efficient, it's more effective, and that it ultimately produces a learning health system, or a series of learning health systems within and across countries that enable broad realization of the quadruple aim, which is described in the middle of this diagram. Other speakers have mentioned that as well. So as I mentioned, about a year ago, as a group was developing in great detail descriptions of what that future vision looks like exactly and what stakeholder-driven steps to get there would look like. We've been meeting together on a weekly basis on Fridays, and we started turning attention in March of last year to how to help this group address the crises that we were facing, that we've heard very intensely about in the earlier panels, how to help these individuals and organizations rise to this incredible challenge in ways that would help them improve how they delivered care to patients, ideally improved outcomes for at least the selected targets that the organizational participants were working on. And again, because this was a part of this broader collaborative and roadmap development effort to try to do this in a way that would advance tools and standards and collaborations that would be needed to deliver this patient-centered knowledge ecosystem and LHSs, learning health systems, that were called for in the roadmap. So a lot of what the roadmap is about, the ACTS roadmap, and what we're focusing on in the COVID collaborative is the details of what goes on around this evidence to guidance to action to data cycle. So what exactly is going on? And again, we've heard great things that are going on in individual organizations, but again, we've heard a lot about silos, as well as from Yvonne, efforts to break down some of those silos in how we synthesize evidence, how we produce guidance, create tools to put that guidance into action, disseminate those tools, integrate those tools into systems and workflows. So again, we have hundreds of people that are coming together to sort of share information about what people are currently doing at these various steps and how they can do those things better. So what the collaborative is, it's essentially a learning community aimed at accelerating enhancements to that ecosystem cycle in ways that will help the specific participating care delivery organizations address specific targets by sharing strategies and learning and challenges and providing mutual support, and doing this in a way that can scale to many other targets for COVID and beyond, as well as many different care delivery organizations in the United States and abroad. So the focus of the collaborative activities currently are revolving with regard to that ecosystem cycle around three specific targets: the use of anticoagulation in hospitalized patients, diagnosis and management of long COVID or PASC, and severity assessment and triage. And listed here are 4 different organizations that are focusing deeply on the entire knowledge ecosystem cycle for those 3 targets. So as I mentioned, we were having weekly meetings to develop the ACTS roadmap for the first year. And then over the last year, since we've been focusing primarily as we finished up the draft of the roadmap for sharing on a public website, which hopefully will happen in the next several weeks for public feedback, we've been focusing these weekly calls on, as I've described, mutual sharing and support to help these organizations address the specific targets in ways that will be very broadly scalable. So the way we're using the weekly meetings and also a collaborative website that we've established where we're posting information of the sort that I'm going to describe here is what each organization is doing all around the knowledge ecosystem to address those particular targets, the several organizations that I listed earlier. So they're describing things like, for each cycle SEP, what are some major successes that they're realizing. These are leading edge organizations, and some of the things that they're doing are quite innovative. So as they share those things, there are opportunities for other organizations to learn what they've done and potentially adapt some of those for their own things. And they're also sharing what needs and obstacles they're running into and using these calls to provide a mutual support to each other. So some of the calls are focused on organization and target focused sharing, and other of the meetings are focused on individual steps in the ecosystem cycle. So for example, going over in detail what some specific tools or strategies are for addressing specific steps in the cycle. For the last 2 weeks, we focused very deeply, for example, on the CPG on Fire HL7 implementation guide. The collaborative has many leads who actually developed that resource, who shared about what it's all about, and then foster some discussions about how it can be applied more richly for the collaborative efforts that I've described. So this year's worth of work on this ACTS COVID-19 evidence to guidance to action collaborative is actually seeding the execution of the broader ACTS roadmap that I've mentioned. A core of some of the things that are proposed in that draft roadmap is that we identify a small handful of targets to focus on. Initially, COVID-19 is one of them. Hypertension is another proposed target. Preventive care and pain management and opioid use are some of the initial targets that we're suggesting. And then the roadmap is essentially a path to foster things like what I've described we're doing in the collaborative cross-stakeholder coordination, enhancing ecosystem cycle infrastructure, developing and implementing computable guidance and processes for doing that, and evaluation, planning, pilot, and scaling. So even though we haven't yet published the draft roadmap for public comment, as I've described, there's a very large number of organizations that have been participating in developing the future vision and drafting the roadmap details. And there's already 32 organizations whose staff has participated in developing the roadmap, who've provided support letters indicating their organization's plans to align their efforts and investments with ultimate roadmap execution. And GIN is one of the organizations among many in the US and abroad that have provided such letters. So the implication,
Jerry?
I think,
Yep, Jerry, it's Mary, just giving you a 2-minute heads up.
I think we're going to be done in about 30 seconds. Thank you.
All right.
I think the implications for the next pandemic is clear. If we had this evidence ecosystem cycle up and running and highly functioning, I think the bumpy road that we've had to put evidence into guides, into action, and into data and so on to create this virtuous cycle. And as we've heard from some of the speakers, we're far from being there yet. And I think if we can continue to build on the kinds of things that are going on in COVID-End and the ACTS collaborative, COCA, other things that are mentioned, that the next time around, this machine will be up and running and will be much better suited to deal with it. So I'll just close with a call to action. This is sort of an open party. We welcome more organizations to get engaged in what it is that we're doing. There's email addresses here. So be thinking, please, about if there are win-win-wins with what you're doing and how we can cultivate them. As Mary, I think, or others mentioned, tomorrow we'll be further exploring this with those who are interested in tomorrow's session. So thank you very much. And back to you, Mary.
Thank you, Jerry. Thank you. There's been some great chat going on. Juan really charged up some of the audience members, so glad to see that chat going. And there's even a challenge to the speakers, which we'll get to in the Q&A. But for now, let's turn the mic over to Cindy.
Thanks so much, Mary, and thanks to my co-presenters for being so timely. And I feel like from the chat that I'm going to be preaching to the choir here, but I don't mind doing that. One of my favorite things. So my disclosure is that I work for the Agency for Healthcare Research and Quality. The views that I present today are my own. So I want to focus a little bit on the audience for guidelines. And very often we think about the primary intended audience as being the clinician community, the healthcare system. That's who we're speaking to. But I want us to remember that our ultimate audience is the public, the people who are in fact going to be the ones to decide whether to take the guidance or not. So with that lens, let's think about those members of the public. Some of them have chronic conditions, and we already ask a great deal of them. There are a huge number of tasks for people to complete, to maintain or improve their health. And we think that we do a good job in providing them the information that they need to take care of themselves. But I'm going to share these data with you. They come from a survey of low-income Californians. And the left-hand side represents when the responses when people were asked, do you have all the health information you need, or would you like some more? And you can see it's a pretty even split. Some, are I'm fine, thank you. And others say, no, I'd like some more. But then they changed the question and they asked, well, what if the information were clear and easily accessible? And then you can see the jump, that the 55% who said they wanted more, more information turned into 71%. And my interpretation of these data is we're not doing a very good job, that if such a large proportion of people are saying they would want information if it were clear, but initially had the expectation that it wasn't going to be something that they would be able to understand or find or use. Let's think a little bit about some of the assumptions that lead to miscommunication about the diverse audiences that we're trying to reach. So there are assumptions that we make about people's literacy and numeracy, about what they know in terms of medical terminology, medical concepts, or even how their body works. And we often forget the diversity of the population in terms of socioeconomic status, the languages we speak, what our health beliefs, religious beliefs, how we practice health behaviors and what we take. So I'm going to dive a little deeper into the literacy and numeracy numbers because that's my particular specialty. And these data come from something called the PIAC. It's an International Assessment of Adult Competencies. And on the left side, we have literacy. And you can see that 28%, this, I don't know if you can see my cursor, but over here, oops, my cursor just advanced my slides, that are at the lowest or below the lowest level. So that means that they are functionally not literate. And a full third are just above that level. So we've got pretty much half of US adults who struggle in some ways around literacy. And it's even worse for numeracy. We find numbers hard to understand. 30% are at the lowest or below the lowest level, and another third are struggling. So what does that mean for health literacy? And you'll see at the bottom of this slide, I have a new definition of health literacy that comes from Healthy People 2030. It's sort of half of the definition, the personal side of health literacy, which is people's ability to understand, to find, to use information and services. And fortunately, health literacy doesn't depend only on people's skills and abilities. It also depends on how easy or how difficult we make health tasks, how complex and difficult we make the information. If we can reduce those demands, we can actually increase health literacy. And so I look a lot in organizational health literacy, which is trying to help health systems and organizations that provide health information make it easier. I like this quote from the former Surgeon General, Regina Benjamin, because she rests accountability right on our shoulders. She says, if patients' understanding is incorrect or incomplete, we did not find the right way to reach them. Being health literate is just as important for clinicians as it is for patients. So I want to share with you some reflections from the COVID-19 pandemic and some guidance that was given on the CDC website. And the CDC, like all of you have been describing all day, was very, chasing the science, trying to keep up with the evidence, making sure that things were accurate, and putting out what we understood about it. And here they gave guidance about providing a separate bedroom and bathroom for a person who's sick. And it's pretty easy to understand. The problem is that there is a large percentage of US Americans who don't have a separate bathroom or bedroom, that this is a luxury, that this is in no way implementable. And when you say it and they hear that, they think, you are not talking to me. You got to be kidding, and dismiss what you're going to say. So then we learned a little bit, and we realized that we had to acknowledge the realities that people were living in. And so we caveated it. We said, well, if it's possible, and do it as much as you can. And then we got even better. We actually provided alternatives. We said, okay, we understand not everybody's going to be able to have their own bedroom. What can you do if you're sharing a bedroom? And here are some concrete things that you can do to try and reduce the risk of contagion. So we've learned something here. And what we have to do next time is make sure we don't forget those lessons. We have to make sure that we make the information easy to understand, easy to act on, and relatable, that they have to see themselves in this guidance. And we have to watch out for that bias. We saw that this was sort of, we tend to write to the middle class. If we write to the average American, half of the people, because average means the median, half of people are not going to understand that. But we only know what we know. How do we know if we're introducing bias? Well, I'm going to double down on Juan's theme here. We've got to involve the audience, diverse members of the audience from the beginning. And we have to establish in advance some testing protocols, because what happened is, that in the rush to get out information and the rush to try and make it be as current with the evidence as possible, we decided that testing messages was a luxury we couldn't afford. It's an afterthought that we don't have time for. So let's learn. And now I'm also going to raise an issue that Juan raised, which is about trusted messengers. So for most people, their personal clinician is a trusted messenger. They may distrust the medical establishment, they may distrust systems, but that doctor that they see, they may trust. Not everybody. But we can't ask those clinicians to do the translation, to say, take this guideline that's written in medicalese and make it accessible for your patients. We need to help them by providing scripts, not that they're going to read the scripts, but that give them plain language and non-medical terminology to be able to explain things, to talk about risk, which is so difficult. And we need to promote ways of confirming understanding, that patients are understanding what we're telling them, like using the teach back method, which means asking someone to say in their own words what they thought it was that you explained to them. And to encourage shared decision-making, because ultimately it's my decision. Am I going to take that vaccine or not? It's up to me. And so you better find out about what my goals are, what my values are, what my preferences are, and help me reach that decision with the best evidence that's available. And to supplement that interaction with people by providing multilingual, because we have also something like 20% of our population who are limited English proficient speakers, making it easy to understand and actionable print materials. So I am going to leave you with some resources to help you do that. Some of these are on the ARC website, some of these from other agencies at HHS, but all of them can help you find your way to that very, it's the most humbling thing that I do, is trying to make information easy to understand. It is really difficult, but maybe some of these tools can help you. Thanks very much for listening and for hanging in for that last speaker of the last panel of the day.
Thank you, Cindy. Thank you very much. So I hope that the audience, is curious, is stimulated, has, lots of questions for this group. You see, this group took a slightly different tack than some of the others, but builds on. And Juan, I loved how you even went back to the keynote and one of the things that Mr. Dowling had said. So spot on, way to try to keep the common thread going through all of this of the challenges of guidance during situations like COVID-19. Yurato, do we have any questions?
We have a long list of questions, so let's get to them.
Let's go.
The first one is for Dr. Flores. Do you think there should be a permanent network set up that gets initiated at future outbreaks or pandemics? Is there any specific advice based on COVID-19's experience that you would suggest for such a group?
Sorry, Gerardo, I didn't get the first part of the message.
Do you think there should be a permanent network set up that gets initiated at future outbreaks or pandemics?
Oh, absolutely. Given what happened with COVID-19 and the need to provide rapid guidance, and we were not prepared. But the whole world was not prepared in every other factor or domain of our life. But considering the what we learned from COVID-19, this could be an excellent opportunity to maintain this network of experts in evidence synthesis that could not only provide what would be the best way to synthesize the evidence, but also how to do the knowledge translation of this, what would be the target objectives, and not only about clinical work, but as I mentioned, in COVID-19, we don't only focus on the clinical management. We try to focus on public health and other societal and economical perspectives. So all these factors, as we saw with this pandemic, the virus affected everything, not only the healthcare management, but also society and economic and policy responses. So it's important to establish this network in advance, in which most, or at least the most important organizations that are interested in evidence synthesis and evidence-based guidance should work collaboratively. We should take advantage of what we have done with COVID-19, with COVID-19, and also what ACTS is doing to continue at some point with this specific. And it's not only about evidence synthesis, it's also about policymakers, patients and citizens, and trying to keep this cycle of input, evidence, and users, and evaluating all the process like Jerry already showed. That would be key to facilitate the process, make more efficient use of resources, and reducing the gap between the evidence production to the final practice implementation.
Yeah, I think it not only behooves our community to make this permanent, but it's also our responsibility to make sure that this becomes permanently part of our work. So thank you for that. Mary, our next question is for Juan. Juan, you have a lot of questions, but I think this one summarizes it pretty well. How can groups that are interested in having more consumer input best reach out to those consumers and engage them better, especially in light of some of the trust issues you mentioned with government and healthcare organizations? So as you know, Juan, our community is starved for consumer input, but we always fail at incorporating the consumer voice in an effective manner. So we have you at our disposal, so tell us how.
First, thank you for such a loaded question. And that's one of those, the question, it takes more than 60 seconds to really capture. I tend to lead workshops on how to really better engage and include consumers, patients, relevant patient populations. But one thing I can say is, one of the consistent things I notice is too often we try to make withdrawals from relationships we have not made deposits in. And when we come across those set relationships of communities, we cannot identify meeting them where they are because we're not familiar with them. We had one-off in contact engagement with them. And then thirdly, once we're done with our hypothesis, our current project terms, we do not revisit them. So real quickly, to help to begin to repair and heal and connect from that process, it is meeting people where they are, not only physically, but psychologically, sometimes as communication, passing the mic, identifying somebody that's on your team that may not be at the executive senior level, but they have relevant experience to identify whether it is communications, access, points of access. The next point is really essential, is understanding relationships is an ongoing thing. Do not try to make withdrawals without having an adequate amount of deposits, because just like when you go to the bank, you cannot expect to withdraw $100,000 and you only deposit $10. And that's how I'll try to quickly conclude and answer that question. Hopefully I answered it properly.
Thank you so much. It's a great starter for our next big conversation about how to incorporate consumers more effectively. I had a question for you as well. in our organization, telehealth is a big thing right now, as it is for most organizations in North America, I imagine. And you mentioned in your talk that one of the reasons a lot of consumers, or those in your community, particularly in Baltimore, went to Facebook to seek expert opinions was because of their lack of proximity to their trustworthy practitioners. So this community has great faith in telehealth, but we're very engaged in it. How do you feel that the non-healthcare, the consumers outside of this healthcare system are going to take to telehealth as a new form of care delivery? Because it's still going to be a physical proximity issue.
That is a challenge that we're still currently working on beyond the health industry. I'm also working in other industries of subjects and helping them to understand consumer insights as it relate to this new digital realm. But the thing is repetition. Constantly, now that we're doing telehealth and more of a physical social distancing, we have increased the amount of engagement and understand that with the saturation of information, we're being bombarded. We went from you have to capture somebody's attention and maintain it from 45 seconds, it dropped down to 15 seconds. So just to understand that now we got a limited amount of time to capture your attention, capture your interest, sustain it, and then repeat it over time. So we got to increase the frequency in which we engage people.
Thank you so much. We have a question for Dr. Ostroff. How can the types of targets you mentioned be piloted in a way that can better assure those targets are applied broadly in practice and not just in theory?
If I understand the question correctly, that's the whole thrust of what we're doing in this collaborative. So it is all about practice. As I mentioned, in March of 2020, we had dozens of people that were getting together on these weekly calls who said, you know, my goodness, it looks like everything's about to hit that fan really soon. How can we respond to that better? And we had spent the previous year thinking of, you know, talking about the theory, what needs to happen, what kind of things could people potentially do? And then all of a sudden in March of 2020, it was like, oh my God, what are we going to do tomorrow? What are we going to do next week or next month? So those targets that I mentioned, long COVID, anticoagulation, triage and risk assessment, those organizations, so the VA, the University of Minnesota, OHSU, and health centers that are managed or supported by NAC, they are caring for patients every day. So this is real world. In Minnesota, for example, they have 12 hospitals that ever since last March, they've had decision support and measures that offer support for clinicians about decisions about putting patients on anticoagulation. And they're trying to keep that updated as that evidence evolves. So this is real world, everyday, real patients, 12 hospitals. And this work is about how can we help them do that better? How can we help them? They're already doing Herculean things around that cycle, from evidence to guidance to action to data. So how can we help them do that better? So it is very real world focused, and the idea is to sort of go back and forth between, let's use these as real case examples, figure out what we need to do to make the world a better place. The whole thing has sort of a boiling the ocean kind of feel, and one of the ways of looking at it is, well, we're just seeing, can we make cups of teas in these places while we step back and try to figure out how to boil the whole ocean in theory.
Thank you. Cindy, I know you want to participate with addressing some of the questions you've noted in the chat, but there was a private one sent to me and it's a little bit more general. So I'll put it out there and you answer it however you want to answer it, combine it with the others. How can scientific experts help ensure that information that is communicated for the consumer, i.e. not for scientific experts, is able to be better understood and remove bias? What kinds of steps can they incorporate into their usual process? I think it's just seeking more practical advice from you on how we could sort of address them.
So I think that there are multiple steps. I mean, I think that you have to budget time for the process of that translation from the medical, professional guidance to what will be understandable to consumer. The tools that I showed before Some of them are very concrete about how to write effective material, specific guidance about not only making the purpose really clear, but even the formatting and the organization of how to have clear titles and chunk information into sections. We know how to do that. The bias one, I think, is a little trickier. And again, there is nothing like testing with your intended audience and making sure that those testers are diverse. And I'll pull in one of the comments from the chat into this, which was that Janice had raised the issue of payment. And so very often we ask people to volunteer their time to be able to participate as a patient representative or advocate on an advisory group or a feedback panel and things like that. And that actually, the failure to pay them introduces bias, because only people who are financially secure, have the employment situation that gives them flexibility or time are going to be able to participate in that. And so you're going to lose those very important voices. And also you'll lose them if you don't have interpreters or have, specific groups that speak the languages that you were of the people that you were trying to reach. So thank you, Janice, for raising that question. I think PCORI gives us a nice model for paying for that patient perspective to acknowledge both the value of their time and to enable people who otherwise would not be able to afford to participate. Thanks.
Thank you, Cindy. Mary, you want to end the session as we're nearing our time and we have a few pieces of information to convey for tomorrow?
We do. But first, let's take a time to thank all of our speakers today, not just panel 3, but our keynotes, panel 1, panel 2, panel 3. Yay, hand claps, love it, Sheila, with your emoji, send a chat. I know people have been chatting this up, but the time that the speakers took to prepare, we were working with them. They gave their time to contribute, and we're most appreciative of that. So thank you to all of today's speakers. We set out at the beginning of planning this 2-day event to reflect on the COVID-19 experience in our North America region and to explore how we, in the evidence-based clinical practice guideline ecosystem, can do better the next time. In doing so, we realized we needed to attack this a couple different ways. The first way was this day, where we brought experts and those in the field who could relay to you what their experiences were. And then the next part is what we're going to do tomorrow, where we're going to learn from each other as peers. And so we hope that you have found so far that this has lived up to your expectations, and that you're now better informed to improve discussions, actions, outputs, and outcomes. If you register for day 2, we look forward to seeing you tomorrow virtually. To that end, I think Yurado is going to put in the chat, if she hasn't already.
I asked Christy to do it, so I think Christy might be.
Is Christy still on?
Yes.
Is Christy Zuber our skill?
We will email all day 2 participants the marketplace again later today.
Okay, so we have a spreadsheet that serves as the foundation for our marketplace of topics. And we encourage you, and I saw there was a chat going that Sharon started about community health workers, and Juan latched on, and Tiffany agreed that would be a good one. So someone needs to put that in the marketplace of topics if it isn't there already. So when the link to that spreadsheet comes around again later, make sure it's in there. Review that spreadsheet, enter your ideas. You don't need to be an expert to host a discussion. You're a host or a hostess. You could just be curious like me and seek answers to lots of questions. you could consider what you heard today and reflect on that marketplace. What's missing? What would make good? How do we answer some of Mr. Dowling's questions? How do we address questions that you've put in the chat? Tomorrow morning, we're going to return to this spreadsheet. We're going to seek final additions and then do the work to finalize it, which in and of itself can be rather invigorating activity. We're looking forward to it, and I hope that you are too if you've registered for day 2. Day 1, as a reminder, has been recorded, and it will be made available to you soon, and so that you can share it with others. For now, we just encourage you to keep staying safe and to have a great evening. Jurado, before exiting though, I want to turn it over to you to make sure it's a wrap, and I'll let you do the final. Thank you, everybody.
Sure, and I am speaking on behalf of Peter as well. And Peter, feel free to unmute yourself and chime in and say your goodbye as well. So again, as Mary stated, we want to thank all our speakers and guests for presenting us with so much to reflect upon, and more importantly, so much to build upon. And I'm going to use one of Dr. Osheroff's phrases: you have all provided so much for us to build upon for our shared future vision. And I really also want to call out that a lot of our participants and our speakers are also frontline clinicians, and we really appreciate your service throughout COVID and for also taking time to be with us today. So those in the Guideline and systematic review community, we have our work cut out for us. There is a lot to do. There's a lot of change. A lot of it is exciting. It's a little bit scary, but I think together and continuing to collaborate in the manner we have today, and especially how we're going to collaborate tomorrow, we can succeed, and we will be better servants for our communities. So thank you. And as Mary mentioned, evaluation forms and recording announcements will be made available in a few days. Thanks again, everyone. Peter, would you have something to say on behalf of NIAM?
Just to echo what you just said, and wish people a good contemplating between now and tomorrow for those who are going to. There was a tremendous amount of content presented, and tomorrow we should actually work on bringing some form to it.
Perfect. Thank you so much, everyone. It's a wrap.